Okay, hope I'm audible. Yeah. Okay. Okay, we'll start the questions. We are moving on from the remaining questions because I have at least 100 plus questions to be discussed. So let us start the discussion. So patient underwent gastrectomy and after eating within 20 minutes sweating, diarrhea, what should be the cause? So this is a very classical question on dumping syndrome. So please remember, this is about the dumping syndrome. So please understand the concept. What does it mean by dumping syndrome? Any gastric surgery you do, any gastric surgery if you are going to do, that will cause a complication known as dumping syndrome. Dumping syndrome is nothing but the food, instead of staying in the stomach, is now directly entering into the jejunum. So directly the food should be usually staying in the stomach, will be digested little by little, and small food particles will usually enter. But in a dumping syndrome, what happens? We have done a gastrojejunostomy here. The food particles will immediately go into the jejunum. So what will happen? The food particles which are hypertonic is going into the jejunum will cause massive fluid shift. Okay, massive fluid shift. To make the fluid as isotonic, there will be a fluid shift. So this fluid shift causes within 30 minutes hypovolemia. Please remember, within 30 minutes there will be hypovolemia will be seen. This is known as early dumping. So within 30 minutes there will be hypovolemia. You know very well what will happen if there is hypovolemia. They will have giddiness and they may have some like sweating, diarrhea, something may happen. Okay, that is early dumping syndrome. But the problem is after 1 hour, the sugar is entering into the circulation, will go and stimulate the insulin. Insulin is secreted in enormous amount that will come and neutralize the sugar, resulting in 2 hours. What happens? In 1.3 hours to 2 hours, there will be hypoglycemia which will happen. So that hypoglycemia is seen after 1.5 to 2 hours. Actually, this question should have patient underwent gastrectomy after eating within 20 minutes, developed sweating, diarrhea, and what should be the cause? So we have to take care here about the minutes. So within 20 minutes, what happens is known as early dumping. If the same question was given as 2 hours, I would have gone for late dumping. So this question is classically on early dumping syndrome. So please remember, early dumping is due to hypovolemia. Hypovolemia. So when you measure PCV, there will be hemo concentration will be seen. Late dumping is due to hypoglycemia. But hypoglycemia is seen after 2 hours. Hypovolemia is seen in 30 minutes. So the question is very clear, which happens within 30 minutes. So we should go for early dumping syndrome is the correct answer for this question. Okay. So this is the 15th question on simple question on dumping syndrome. This is a very classical national board question, dumping syndrome. Please don't forget this. Risk factors of esophageal cancer are all except. So I'll tell you, for FMGE exam, all cancers you should know the basic risk factors. Definitely they will ask you the risk factors in esophageal cancer. So please remember, risk factors for esophageal cancer are all except. So you should know here, I'm going to discuss two headings. Risk factors are two heading. One is adenocancer. In esophagus we have adenocancer and we have squamous cell cancer. Squamous cell cancer is most common in esophagus. Okay, very common in esophagus. It is characterized by, squamous cell cancer is caused by even drinking of hot tea, coffee, any hot drinks, or corrosive ingestion, corrosive acid or alkali consumption, smoking, alcohol. Okay, alcohol. Achalasia is a predisposing factor of squamous cell cancer. Achalasia, corrosive ingestion. Please don't forget antioxidant deficiency. Antioxidant deficiency. All this can cause squamous cell cancer. There is only one predisposing important factor for adenocancer, that is nothing but GRD. Because of acid reflux that results in Barrett's. So that is the cause of adenocancer. So adenocancer is because of GRD and Barrett's. Squamous cell cancer is due to corrosive ingestion, smoking, alcohol, achalasia, Plummer-Vinson syndrome. So many other causes are there, but please don't forget the basic causes. So this question, except yes, GRD causes adenocancer. Tobacco chewing is nothing but like a part of smoking. It's also causing esophageal squamous cell cancer. Antioxidant deficiency will cause esophageal cancer. Nitrate foods, nitrates will cause more of gastric cancer. Okay, nitrates are more associated with the gastric cancer and not with esophageal cancer. So the odd man out is the odd man out is gastric cancer. Okay, the odd man out is for nitric food, it is gastric cancer. So please don't forget this basic point. And this is a 100 times asked question. Alvarado score 2 defines dash. What is it? Alvarado score, 2 points are given. First of all, tell me where will you use Alvarado score? Alvarado score is a scoring used to diagnose acute appendicitis by clinical and laboratory values. Clinical and laboratory value. Without using ultrasound, I can diagnose acute appendicitis by using a score known as Alvarado score. Yes, Alvarado score. So Alvarado score is correct. Scleroderma is another etiological factors for adenocancer. Correct, Herman. That's correct. So the mnemonic is Mantrals. The mnemonic of Alvarado score is Mantrals. M for migratory pain. A for anorexia. N for nausea. T for tenderness. McBurney's point tenderness. Rebound tenderness. Bloomberg sign. Elevated temperature. Leukocytosis. Shift of neutrophils to left means there are more of immature neutrophils. There will be immature neutrophils. So these values are taken. Every fellow is given 1 point, 1 point, 1 point, 1 point, 1 point, 1 point, 1 point. Two people are given 2 points. One is tenderness and leukocytosis. We will give 1 plus 1 point. So total score is 10. When it is more than or equal to 7, it is a clinically acute appendicitis. Okay, it is clinically acute appendicitis. Very good. So the mnemonic is Mantral. Please remember the score name is Alvarado score. The mnemonic is known as Mantrals. So please don't forget TL will have 2 points. All other thing will have 1 point. So total score is 10. If it is more than or equal to 7, it is Alvarado score. Positive for acute appendicitis. So Alvarado score 2 defines for leukocytosis. The answer here is leukocytosis. Tenderness not in the left iliac fossa, it is in the right iliac fossa. McBurney's tenderness, it would have got 2 points, but it is given as tenderness in the left iliac fossa. It is not correct point. So leukocytosis is given 2 points. Okay. So tenderness and leukocytosis will have 2 points. Please don't forget that. So I'm putting the we have completed general head and neck, thyroid, breast questions of FMG expected series. Now we are in FMG series of gastrointestinal tract. We are discussing patient suffering from ulcerative colitis presents with an ulcer on the anterior leg. So this is a classical image based question. An ulcer is seen on the anterior leg in an ulcerative colitis. In ulcerative colitis, we get one skin lesion commonly. What is that skin lesion? Ulcerative colitis is a disease of colon. They can develop an extra-intestinal manifestation. One of the most common extra-intestinal manifestation is pyoderma gangrenosum. This is a picture of pyoderma gangrenosum. Please don't forget this question. Can you tell me what is the picture seen in Crohn's disease? Crohn's. So please don't see the image and answer. Always read the theory given. If you are going to read the theory, you will definitely never answer venous ulcer, because this is the question discussing with the ulcerative colitis. It's an ulcerative colitis causing an inflammatory skin lesion, pyoderma gangrenosum. Anybody, can you tell me what is the lesion seen in Crohn's disease? Can you tell me the lesion seen in Crohn's disease? It is erythema nodosum. Please don't forget, erythema nodosum is a skin lesion in Crohn's. Pyoderma gangrenosum is a skin lesion in ulcerative colitis. Some simple clinical examination test only they are going to ask you in the exam. Some simple clinical test. So this is a clinical test showing a patient has a gross abdominal distension. It's nothing but ascites. There is an ascites. And the following test is being performed. Comment on the test done. This is a very basic medicine question. You know very well. A very good, Herman. That's erythema nodosum. That's correct. So Previous question, some of you have answered as B. Please remember, we should read the question before answering the choice. Don't go on directly into venous ulcer. Yes, venous ulcer is a commonly kept exam case, and it will be seen on the medial malleolus. Okay, it is history you should not forget. So this is a picture showing you shifting dullness. Sorry, this is a picture showing you fluid thrill. Okay, this sign, what will you do? When the tense abdomen, we ask the assistant to come and compress this side, and we tap from opposite side to other side. So when you tap from one side with the other side, you can see the surgeon is tapping this side. You can feel the thrill on the other side. This is known as fluid thrill. So fluid thrill. Fluid thrill is usually seen when the fluid amount of ascites is more than 1 liter. Please remember, fluid thrill is seen when the fluid is collected more than 1 liter. Shifting dullness, you have to percuss and you have to ask the patient to turn to the other side and then percuss again. The resonance will be there. The dullness previously seen will become resonant now. That is seen for more than 500 ml. Shifting dullness is for more than 500 ml. Very interesting is puddle sign. Puddle sign is an expected MCQ clinical based question. Patient will be put in knee elbow position. He will be sitting like this. And at the umbilicus level, we have to percuss. At the umbilical level, if you percuss, there will be small amount of fluid like 30 ml or more will be seen positive. So puddle sign, the patient will be in a knee elbow position. So shifting dullness is for 500 ml, fluid thrill is for 1 liter, and puddle sign is for 30 ml. So you might be getting some more things from medicine, but I don't know. Hingorani sign is, I don't know what is that sign. It was given in the choice, but answer for this test done is fluid thrill. So this is actually probably a medicine clinical question. Okay, this is probably a medicine question. Puddle sign may be expected question. It's for testing small amount of fluid. Okay, so this is for testing. So this question has been, I was seeing this question in every paper in AIMS or FMGE or NEET tests. Everywhere this question will be asked. A 60-year-old man presented with a projectile vomiting, significant weight loss. Which of the electrolyte abnormality is seen? So basic question. A patient having gastric outlet obstruction. See, this is the stomach which is not allowing the food particles to go inside. The food particles which are staying in are vomited because of there is an obstruction. It is seen in congenital hypertrophic pyloric stenosis, cancer stomach causing obstruction, duodenal atresia. Any obstruction can cause the same electrolyte abnormality. What he will be vomiting? As he is going to vomit, initially what is going to come is HCl is going to come. Hydrochloric acid seen in the stomach is going to come. So therefore there will be metabolic alkalosis. Please remember, there will be metabolic alkalosis. First thing you should not forget is metabolic alkalosis, because he is vomiting the acid. Since he is vomiting the acid, he becomes metabolic alkalosis. And chloride level, hypochloremia. This is a basic electrolyte abnormalities in hypochloremia and metabolic alkalosis, because he is vomiting acid. Chloride level, acid level decreases. Then comes the compensatory mechanism. When the acid is being vomited and alkalosis sets in, what should we do? There is a huge mechanism behind that. There will be renin-angiotensin acting, and they will try to preserve they try to secrete the bicarbonate outside. What will happen in the urine? Bicarbonate should be excreted, but here instead of bicarbonate, there will be acid itself will be excreted because of a huge phenomenon, and this time is not sufficient for explaining that. But please remember, there will be metabolic alkalosis, but there won't be bicarbonate excretion. Those guys will excrete acid. Therefore, it is known as paradoxical aciduria. Please remember, paradoxical aciduria. Very important point. Because of this, there will be paradoxical aciduria. Because instead of bicarbonate, there is acid is going to be excreted as a compensatory to prevent the loss of other anions, because they will be losing sodium, they will be losing potassium, they will be losing calcium. So please remember, the electrolyte abnormality seen is hyponatremic, hypokalemic, hypocalcemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Classical line. This question will be again and again repeated multiple times. So please remember, hyponatremic, hypokalemic, hypocalcemic, metabolic alkalosis. In a metabolic alkalosis, patient should actually excrete bicarbonate. He should excrete bicarbonate. but instead of bicarbonate, he is going to excrete acid. That is why it is known as paradoxical aciduria. So the question is very clear. This is hypokalemic, hypochloremic, metabolic alkalosis with hyponatremia. All the values will decrease. Okay, remember all the sodium positive ions will decrease. Sodium, potassium, calcium, chloride, everything will decrease in the case of GOO, gastric outlet obstruction. All are decreased. So the moment you see this image, you will burst out with the answer, because this is 100 times asked image. There is a sign known as class sign you are seeing in a barium enema. Class sign is a sign seen in intersusception in a barium enema. So please remember, intersusception is a very favorite question for national board exam. There are 5 questions which will be definitely asked in intersusception. So if there is a clinical scenario telling there is a baby brought by the mother with a clinical feature of dash, you should immediately bounce as intersusception, that is red currant jelly stools. Please remember, when there is a red currant jelly stools, the patient is having a red currant jelly stools, there is a chance it can be a intersusception history, number 1. And on examination, the right iliac fossa will be empty. Because of the intersuscepted mass, the right iliac fossa will be empty. That sign is known as Lee-Dancy sign. Lee-Dancy sign. And there will be a sausage shaped mass near umbilicus. So empty right iliac fossa with a sausage shaped mass near umbilicus is another clue for an intersusception. And the moment you see such case, when I do an ultrasound, that is an investigation of choice, that will show me target sign or bull's eye sign. Target sign or bull's eye sign is seen in ultrasound, but some old surgeons still they do barium enema. Barium enema will show class sign, and what is this sign known as? What is this sign? Coiled spring sign. Okay, coiled spring sign and claw sign are seen. Simple question. So claw sign and coiled spring sign are seen, and the treatment is we have to go for ultrasound guided saline enema. Now this PDF will be shared, Imad, don't worry. Whatever I am writing, no, this PDF I will share in the Telegram channel. You can download that. So ultrasound guided saline enema is a treatment, or air enema is a treatment for these type of babies. It's for only children, small children, but not for this old man. If it is an old man with intersusception, we should operate. But children less than 2 years, we can treat with ultrasound guided saline enema can be used. So please don't forget, intersusception is a favorite question for national board examiners. Another repeat question. I'm telling you, FMGE exam, the repeats are so common. You will get repeat question from the same basic concepts. I am discussing August 2020 question. You will see all these questions will again come in 2021 and other exams, 2022. A female patient with dysphagia, barium swallow is shown. So whenever there is a dysphagia, only 2 cases will be kept in the exam. One is this, known as bird's beak sign. One is a bird's beak sign seen in achalasia, seen usually in younger age group. So barium swallow in a young age group will show you bird's beak sign. Another sign is this. So this is another sign. So this is a rat tail. You can see rat tail will have a irregular narrowing and tapering. Rat tail appearance is irregular narrowing, which is seen in cancer, specifically for cancer. There may be misusing of each terms, but correct answer is achalasia, bird's beak, rat tail cancer. Rat tail is seen in cancer. So the female patient with the dysphagia, barium swallow image is shown here. What is the likely diagnosis? It's a case of bird's beak achalasia cardia. So in this, you can always see for the age. In a achalasia, there will be young female, the word will be mentioned. In a cancer, there will be a old male which will be mentioned. So without even seeing the image, you can come to your diagnosis. Okay, please remember this question. Such a simple question, basic question, you should never make a mistake. A man presented with vomiting and nausea and fever. He was admitted for appendicectomy after diagnosing appendicitis. During surgery, surgeons found an incidental finding, that is this. Another favorite topic of FMGE, this is Meckel's diverticulum. See how simple the questions are. They expect you to just know the concepts. They don't want you to even explain or understand in depth. They just want you to know there is a disease Meckel's, which need not do anything during the surgery. When you are seeing during some other surgery, just leave it. Bailey says such a wide base Meckel's, just leave it. No need to even operate that. What is Meckel's? That is my question for FMG exam. What is Meckel's? Meckel's is a persistence of what? Persistence of vitelo-intestinal duct. Please don't forget, it is a persistence of vitelo-intestinal duct. This is the duct which is actually in the baby providing nutrition directly into the GIT through the terminal ileum, because it is seen in the terminal ileum 60 centimeter proximal to ileocecal junction. This is connected to the umbilicus of the baby. So when the baby is in the uterus of the mother, this nutrition from the mother is directly entering into the GIT through this vitelo-intestinal duct. So after birth, this is not needed because baby is going to eat by this mouth. Therefore, this duct will disappear. If it is persisting in the proximal part, it is Meckel's. If it is persisting in the distal part near the umbilicus, what is it known as? Proximal part is Meckel's. Distal part is known as raspberry tumor. Very interesting MCQ. Raspberry tumor. If it fully persists, what will happen to the baby after birth? If it is fully persisting even after birth, you can see through the umbilicus, feces will come out. Feces coming via the umbilicus. Please remember this again an FMG question. Embryology based question. Feces via umbilicus. Yes, vitelo-intestinal duct is fully persistent. It is coming because the vitelo-intestinal duct is persistent. Who will get urine from the umbilicus? Urine from the umbilicus is from persistent urachus. Vitelo-intestinal duct causes feces. Persistent urachus connected to the bladder will cause urine coming from the umbilicus. Simple basic embryology questions. Okay. So what is this procedure used for? This is a procedure, not an image based question. For your understanding, I put this question. This is Dilmens procedure, which is used to treat the Zenker's diverticulum. Okay. This is Zenker's diverticulum, also known as pharyngeal pouch. Pharyngeal pouch. So please remember, Zenker is a false diverticulum, Meckel is a true diverticulum. We pass a stapler like this and staple like this, making that into a common lumen like this. So now the food will go like this and go like this. So this is a procedure known as Dilmens procedure, which is nothing but endoscopic stapling procedure. Please don't forget, it is for pharyngeal pouch. Endoscopic stapling procedure for pharyngeal pouch. So you are going to strike all the questions correct in surgery. I am telling you, all these questions will be repeated. This year, the percentage of pass is going to be very high. So definitely you will answer all these questions. So which of the following is not a natural constriction of esophagus? Not a natural constriction. So which is not a natural constriction? So I want to tell you here, at 15 centimeter, when I put an endoscopy, at 15 centimeter, there is a natural constriction. At 25 centimeter, there is a natural constriction. At 40 centimeter, there is a natural constriction in the esophagus. A question from Bailey. So what are those natural constrictions is the question. At 15 centimeter, the first constriction is cricopharyngeal muscle, cricopharynx. That is the first narrowing at 15 centimeter on putting. So cricopharynx is the first narrowest part. At 25 centimeter, we have arch of aorta and left bronchus. So arch of aorta and left bronchus together form a constriction at the level of 25 centimeter. At 40 centimeter, it is lower esophageal sphincter which causes constriction. Now come to the question. So cricopharynx, arch of aorta and left bronchus at 40 centimeter LES. So the constrictions are seen in pharyngoesophageal sphincter, junction S, cricopharynx, aorta, diaphragm. Not at thyroid position. Thyroid has nothing to do at the level of natural constrictions. Okay, only when the thyroid is very hugely enlarged, it will compress the esophagus. Otherwise, it will not compress the esophagus. So the constrictions are the 15 centimeter, it is cricopharynx, which is nothing but pharyngoesophageal junction. 25 centimeter is aorta and left bronchus, and 40 centimeter is OG junction, that is the diaphragmatic area. So these points you should not forget. So which of the following is not a natural constriction? Answer is A. Okay. When I was taking the recent classes, you know very well, I was discussing about the stomas again and again, because I am sure this year also they are going to ask you on stoma. So identify the stoma in the right iliac fossa. So the point you should note here is which area it is located is going to help you, whether it is an ileum which is out or colon which is out. If it is in the epigastric region, please remember this transverse colon comes here. So in this region, if you see a stoma, it is colostomy of transverse colon. Same way, if you see a colostomy in the left iliac fossa, it is a colostomy seen in the left iliac fossa. We again see a colon. So please remember, stoma in the epigastric region is colostomy. In the left iliac fossa is colostomy. and this is the ileum. So ileum will be near the right iliac fossa. So right iliac fossa will be ileostomy. So if the stoma is looking like this with only one opening, it is known as end stoma. If the stoma is looking like this, I have brought the bowel like this. So I am seeing one opening here, one opening here. Two openings are seen, 1, 2. It is loop stoma. Now you can tell me this is the right iliac fossa. What is the stoma? What is the stoma? Very good. It is loop ileostomy. Very good, Surami Chaura Sharma. Very good, Jayashri. So it is a loop ileostomy. That's the correct answer is loop ileostomy. So please remember, loop ileostomy is the correct answer. This question will definitely come. They may ask you a left side colostomy or a epigastric region loop colostomy or a end colostomy. Something will come for your exam. Please have the location of stoma and the MCQ based on that. A 5-week-old male child is brought to emergency department with a multiple episodes of non-bilious. This point is catch point. If the baby is coming to you with a non-bilious vomiting, identify the barium image. So what is the name of this sign? What is the name of this sign? Can you see? What is the name of this sign? Radiology question. This is known as mushroom sign or string sign in the pylorus. This is string sign or mushroom sign in the pylorus. Classical finding of congenital hypertrophic pyloric stenosis. Simple question. This is a case of congenital hypertrophic pyloric stenosis. Please don't forget, it's a case of congenital hypertrophic pyloric stenosis. Simple question. Simple question, just once again. So that's a congenital hypertrophic pyloric stenosis questions. You should not get confused with that. So just I want to tell you the important questions which are asked in the exams from the past few years. I am covering all the questions. So next, this is any doubts you have in congenital hypertrophic pyloric, I request you to please get it clarified, because congenital hypertrophic pyloric stenosis is a high yield MCQ for your exam. Congenital hypertrophic pyloric stenosis, the MCQs which can be asked are, what is the investigation of choice to diagnose this? Can you tell me what is the investigation of choice? Yes, very good. It is known as mushroom sign. The investigation of choice is ultrasound, which will show you thickened pylorus more than 4 millimeter, lengthened pylorus more than 16 millimeter, because nobody is doing barium meal nowadays. Nobody is going to do this investigation. It is an outdated investigation. We can diagnose them easily with the ultrasound, which will show you thickened pylorus and lengthened pylorus, and the treatment is going to be a very simple surgery. What is the treatment? It is Ramstad's pyloromyotomy. Please don't forget, Ramstad's pyloromyotomy is a treatment of choice. Okay, the point you should not forget is congenital hypertrophic pyloric stenosis will have non-bilious vomiting. Duodenal atresia will have bilious vomiting. No need of any remembering this by some mnemonic. This is a very simple concept. So for example, this is a pylorus which is hypertrophied. So therefore, whatever in this area only will come in vomiting. That is congenital hypertrophic pyloric stenosis. Where is the bile duct entering? It is entering the duodenum here. So when there is an obstruction distal to the duodenum here, the bile which is coming in the duodenum will come in the vomiting. So if there is a bile vomiting, the obstruction is distal to the ampulla. Please remember, distal to ampulla, any obstruction, duodenal atresia, jejunal atresia, ileal atresia, midgut volvulus, all other fellows will have bilious vomiting. So please remember, bilious vomiting is a dangerous problem. Non-bilious congenital hypertrophic pyloric stenosis is not a dangerous problem. We can easily manage those babies, okay, by Ramstad's pyloromyotomy. Yes, there will be olive-shaped mass near the right hypochondrium is another clinical point. You should not forget that. A male patient presents to the OPD. Male patient presents to the OPD with an abdominal lump in the periumbilical region that moves at right angle to the mesentery attachment. So this is a mesenterical root. Okay, this is a root of mesentery. So this is a root of mesentery, and this is the mesentery. Okay, this is the mesentery which is giving attachment to the bowel like this. So this is a bowel. So if there is a cyst happening in this mesentery, it will produce one triad. Can you tell me what triad it will produce? So it will produce one triad known as Tillot's triad. That is given in the question as clinical features. Tillot's triad. What is Tillot's triad? First point, please remember, this has a sign known as, in Tillot's triad, there is a sign known as Tillot's sign. What is Tillot's sign? So you know very well, the mesentery is attached in this way like this. So if I would like to move the cyst, it will move in this direction freely. It will move perpendicular to the mesentery freely, but it will not move in this direction. It will not move in this direction. So this is known as perpendicular movement of cyst. The first feature. Tilloch striae, a cyst in the mesentery will move perpendicular to the mesentery. Number 1, it will have central dullness surrounded by resonance. So centrally there will be dullness surrounded by resonance. This is a classical feature of chylolymphatic cyst, which is nothing but a mesenteric cyst. It is a mesenteric cyst. So mesenteric cyst, chylolymphatic cyst will have three clinical features. One is Tilloch sign, 2 central dullness, 3 resonance around. That is known as Tilloch striae. It is a classical feature of mesenteric cyst. Okay, this is a very classical question. Question number 29 is 100 times repeated MCQ. So please don't forget this question. The patient, X-ray of the patient after abdominal surgery is shown. Patient is in state of Bilious. What is the most common cause of this condition? Okay, what is the most common cause of this condition? The common cause of this condition is Paralytic Alias. So please remember, this is a case of Paralytic Alias. Okay, this is a Paralytic Alias. So please remember Paralytic Alias. You should understand what is Paralytic Alias. Paralytic Alias is a normal phenomenon which can happen if you do a laparotomy. After surgery, it can normally happen. The bowel will go for a rest. When you open the abdomen and disturb the bowel, they go for a rest. After few days, it will start functioning. The first bowel to recover from Paralytic Alias is small bowel, which recovers in 24 hours. Okay, so 24 hours, the small bowel will recover its function. So then, there is always a controversy. Second bowel, as per Bailey and Love, you just remember it is colon. I am just discussing Bailey, but this is actually wrong. But since it is there in Bailey, I am following this. And the last one is stomach. They will start moving one by one. In 5 days, the entire GAT will start moving. Even after 5 days, if the bowel is not moving, they will get distended with gas like this. So they will get air fluid levels like this. Air fluid levels will be seen, and when you examine, the bowel sounds will be absent. This condition is known as persistent paralytic ileus. We have to tell it as persistent paralytic ileus. It is most commonly caused by electrolyte abnormality. Most commonly, the electrolyte abnormality is hypokalemia. But please remember, it can be caused by anything like hyponatremia. Anything can cause this. But hypokalemia is the most common cause of this paralytic ileus. So please remember, hypokalemia is a common cause of paralytic ileus. So this question is a classical image based question. You can get in exam. You have to find out this question simply by seeing the image. There will be air fluid levels. Gas will be seen in the colon, also will have gas. Rectum also will have gas. Simply you can diagnose it. That is a paralytic ileus. So recently in NEET PG 2022 also they asked a question from a lesion around the anus. So you have to be expecting this question around the anus. So this is a buttock I am drawing here. This is a buttock I am drawing here. This is a normal lithotomy view. Lithotomy view. This is 12 o'clock position. This is 6 o'clock position. You have to find out what is the opening by finding out the location. Please remember, if a picture is given within the anus, somewhere within the anus, some like this, like this, like this, like this, like this, like this, within some 3.5 to 4 centimeters from the anus, if you get an opening, that is usually a perianal sinus, or it can be a fistula. We cannot find out whether it is a sinus or fistula unless you know the inner opening. So around the anus, you see in this picture, this is an anus, within some 3 centimeters, there is an opening. So this is actually a perianal fistula. Many times I am still seeing students getting confused with the pilonidal sinus. So please remember, pilonidal sinus, where it will be seen, the image will be shown in a different way. They won't put a lithotomy position. They will show the buttock from behind like this. So they will show the buttock like this with so much of hair. So hair will be shown, and this is the anus. This opening will be seen in this cleft, in the midline cleft of the gluteus. That is known as pilonidal sinus. So don't get confused with this image. So pilonidal sinus, if they are going to ask you, they will ask you the gluteal cleft only, they will give you in the image. And you can see some amount of hair around. If they are going to ask perianal fistula, they will be putting a position like this, they will show you the holes. So please don't get confused with the perianal fistula and the pilonidal sinus. There is no confusion at all. And perianal fistula will open inside the anus. they will have an inner opening. Inner opening is present in a perianal fistula, and the inner opening is found out with the help of Goodsall's rule. Please remember, it is found out with the help of Goodsall's rule. Goodsall's rule. Okay, Goodsall's rule says the fistulas which are seen anteriorly will drain straight like this. Posterior fistulas will drain at 6 o'clock like this. That is the Goodsall rule. If the fistula is seen anteriorly, they drain straight into the anus. If they are seen posterior to this line, the line drawn from 3 o'clock to 9 o'clock, if it is seen posteriorly, they form a circumferential tract and join the inner opening. Okay, that is very important. Yes, very good, Sharma, that they will be definitely giving you a clue. There is a jeep driver or something for a pilonidal sinus. So pilonidal sinus will have a clue in the question. Driver will be the clue. This does not have that clue. Pilonidal sinus will have a clue. Okay, anterior fistulas drain straight, posterior fistulas drain in the midline. No confusion in this pilonidal sinus and perianal fistula. So this is the one which is going to become a fistula in future. Please remember, this is a perianal abscess. You can see very painful abscess, perianal abscess. This will get infected, will get ruptured and will enter into the anus. So we can do either fistulotomy or fistulectomy. Both can be done, friends. Nothing wrong. Okay, both can be done. So this is a perianal abscess. Patient will have severe pain and tenderness. These type of perianal abscess, if this is an abscess, I should make a cruciate incision like this. So cruciate incision means cross incision will be made, drain the pus. If you drain the pus, that itself is a big relief for him. Slowly they will develop a fistula in future. We will operate the fistula later. Okay, that is a point on fistula. So this question is again, some of you asked a doubt on that day. After binge drinking of alcohol, now you see I have completed 2 papers, 2019 and 20. 2021 papers, you will answer all the questions without any preparation at all, because all are repeat questions of 2019 and 20. So binge drinking of alcohol, a young male presents with sudden vomiting and hematemesis. What is your diagnosis? I discussed this question last class. Binge drinking, Ramu and Somu, I told you, Ramu and Somu are 2 fellows who are going to drink full alcohol, full beer of alcohol they are going to drink. After drinking, these 2 guys are going to vomit. After vomiting, Ramu collapses. BP Kori, pulse Kori, he collapsed. Whereas Somu himself went to the hospital with the hematemesis. So what is Somu? He is Mallory V star. So hematemesis fellow is Mallory V star. The collapsed fellow is Boerhaave syndrome. Who is dangerous? Ramu is in danger. He is having a rupture of esophagus in the lower end of esophagus. Rupture of esophagus seen. He will die. Ramu will die if you are not going to treat him. Be careful. So, but this guy will survive. 90% time the bleeding stops. So Boerhaave syndrome is very dangerous. Needs surgery within 24 hours. I have to do operation. Otherwise Ramu will die. So please don't forget these 2 guys of Boerhaave syndrome and Mallory V star. They are very commonly asked question. When the question is binge drinking, vomiting and collapse, patient is Boerhaave syndrome. Hematemesis, it is Mallory V star. Very simple question. Please don't forget. Okay. Killians Digest is between. Killians Digest. See, again the question is coming. Killians Digest is a defect in the inferior constrictor muscle between the cricopharyngeal sphincter. This is cricopharynx and this is midline and this is thyropharyngeus. This is thyropharyngeus. This is thyropharyngeus of right and left side, and this defect is known as Killian's triangle, which produces Zenker's diverticulum. It's a defect between thyropharyngeus and cricopharyngeus muscle. So this is cricopharynx, this is thyropharynx, this is a triangular defect. Zenker's diverticulum, most common on left side in old age. Okay, old age, it is very common. The treatment done is Dilmens operation. Dilmens operation is done for these guys. See, I told you all the questions, whatever we discussed so far in GIT, again they are repeating. 25 years female, dysphagia, barium shows the following diagnosis. The answer is typical bird's beak achalasia. If you are thorough with the repeat questions, especially in surgery, you are going to answer 70 to 80% of the questions. Absolutely correct. Absolutely you are going to answer all the repeat questions. No doubt in that. And if you are going to be thorough in all the repeat questions of the last 4 years, you are going to crack this exam with the highest score. I can guarantee that. Barium swallow shows, demonstrates. What is this finding? Another barium swallow. See, barium swallow picture of achalasia. Barium swallow picture. This picture is looking like a corkscrew esophagus. This is a picture showing you corkscrew esophagus. What is the name of this disease? The name of this disease is diffuse esophageal spasm. It is another motility disorder. Like achalasia, it is also a motility disorder. So barium swallow demonstrates diffuse esophageal spasm is the answer. So previous question is achalasia, this is diffuse esophageal spasm. So simple practical question. So no confusion. The 9-year-old boy was having dinner with his parents, and after he is swallowing food bolus, he had choking sensation. Next step done. What will you do if a boy is feeling after eating is feeling sad, suddenly food is stuck up here? What will you do next? You ask him to drink large sips of water or Pepsi 7-Up to push it down. So this is a simple question. 9-year-old boy having food stuck up in the esophagus. Probably he has taken a dry food that would have got obstructed. Simply you drink water or 7-Up or Pepsi or some soda, that will push it down. But if you are getting this type of complaint, this complaint is known as episodic aphasia. Episodic aphasia. Suddenly a food bolus getting obstructed in the esophagus. You should think of what this is. It is Skatsky ring. You should think of Skatsky ring. Skatsky ring is a complication developing due to GRD. Because of GRD, they can develop a ring in the lower end of esophagus like this, thin ring. It is a thin ring. It is a thin ring at the squamo-columnar junction between the squamous epithelium and columnar epithelium. There is a thin ring that is known as Skatsky ring seen in GRD. They can develop this symptom of episodic aphasia. But even for them, initially we give them water and Pepsi, 7-Up. Okay, something will be given for them. So this is a simple question. Direct image from Bailey and Lau. The following staging is done for which of the following cancer? So this is a staging known as, what is the name of the staging? Can you tell me? This is Borman's staging of cancer stomach. Polypoidal type, ulceroproliferative type, ulcerative type, Linitis plastica. So these are the 4 types of Borman's gastric cancer classification by gross examination. It's a gross examination classification. Can somebody tell me what is the classification done by microscopic examination in gastric cancer? It is Lawrence. It's a microscopic classification. So cancer stomach is having 2 classifications. Borman's is a gross classification. Lawrence is a microscopic classification of classification containing diffuse and intestinal type. So usually, that is why I usually prefer the Zoom session. This OBS software is always a problematic software. It will have a delay. There will be some buffering. So, but what to do? This DocTutorials people, they are connecting this in YouTube. Now, so I have to connect it in YouTube. If we do the session in Zoom, now it will be pakka streaming will be there. There will be no disturbance. So I will tell them from next session onwards to do a Zoom sessions. There is small buffering, but what can I do? I want to complete today. There is small lag. On and off there is a lag. Not always. On and off there is a lag. I hope you are seeing what I am writing there. Everything what I am saying I am writing there. So following surgery is done for very good Kamala, that's correct. Lawrence classification, Shurmai, that's correct. So Lawrence classification is a microscopic classification. Borman is a gross classification of cancer stomach. So this is a gastric cancer is answer here. So Duke's classification is for colon cancer. True. Duke's is for colon cancer. Okay. So what is the diagnosis in this X-ray? What is the diagnosis from this X-ray? What is the diagnosis from this X-ray? I will tell you, this question is asked 1,000 times. 1,000 times. So 1,000 times this question is being asked. This question is a air under diaphragm. Okay, air under diaphragm. Air under diaphragm is nothing but, what is this air? Can you tell me what is this air? This is a normal fundus gaseoda. So fundus gaseoda, normal fundus gaseoda. So when there is a perforation of the bowel, there is a, for example, this is a bowel or a duodenum, this is perforated, the gas inside will come and will remain here under the diaphragm when you are standing. So in an erect view, you will get air under the diaphragm. That is a case of perforation peritonitis. The immediate treatment is what? Perforation peritonitis. What is the treatment? Whenever you see an air under diaphragm, patient is having peritonitis features, emergency laparotomy should be done. Okay, emergency laparotomy is done immediately. No doubt we have to do the emergency laparotomy for those patients. Okay. So a patient presents with persistent vomiting, what will be the acid-base imbalance? Already you can see, same question is repeating again. Yes, there are so many signs like cupola, Mushtaq sign and all you will be discussing in radiology, but surgery books never mention about any of those signs because we never depend on any of these signs. Whenever we see a patient with a classical feature of air under diaphragm, we will go for surgery. Okay, so this is air under diaphragm. This is looking like a Mushtaq known as cupola sign. This is a bowel, presence of air inside and outside is known as Riegler sign. Huge air under diaphragm is known as American football sign. So all these are various signs, cupola, Riegler, football, all are seen in perforation peritonitis. Okay. So the patient presents with persistent vomiting. What will be the acid-base balance? Already told you it is metabolic alkalosis with the paradoxical aciduria. Simple question, again repeated in a more simplified way. 36 years old male with a low grade fever, anorexia and weight loss for the past 1 year. So during the following image, your following image is obtained during the contrast study. What is your diagnosis? So in this picture, if you see, very classical question, the catch point is very simple here. That's a low grade fever. Who will get low grade fever? In a young male who will have a weight loss for 1 year. So typically this, without, I'm not going to the image at all. I'm telling you, I'm not going to the barium meal. This investigation is known as barium meal follow through. I'm not going to that investigation at all. I am seeing directly the question. So some of you are answering cancer colon. How can you say a cancer colon for a 1 year fellow? Why should a cancer patient get a fever? You should just think about it. So the one choice excluded. Volvulus is an emergency. You cannot just like that go and manage a patient. They will be coming very sick and serious. So therefore two choices are excluded. Diverticulosis of colon is very common in old age, not in 26 years, and that is common in sigmoid colon, and that will show you sawtooth appearance. This question is not asking that. Can you see the arrow? The arrow is showing you there is a narrowed terminal ileum that is known as ileocecal TB or Crohn's. Any one of this only. Ileocecal TB or Crohn's will have this string sign of Cantor. Yes, typically evening rise of fever is a clue, weight loss is a clue. All these are classical points. String sign of Cantor is seen here in Crohn's as well as in TB. Better answer in an Indian case is TB. Okay, so this is a case of ileocecal TB is the correct answer here for this question. 45 years old male complains of pain, abdomen, vomiting on and off, diarrhea. So please remember, patient is complaining of pain, abdomen, vomiting and diarrhea. Measurement of serum creatinine is very high. What is the probable diagnosis? So pain, abdomen, vomiting on and off, diarrhea, serum creatinine is high. What is the probable diagnosis for this case? So it can be a carcinoid tumor. Very simple question. It can be also a adenocarcinoma because of persistent vomiting. So this patient, because it's given as diarrhea, that is a catch point. Each question will have one catch point. So this patient is having diarrhea. So diarrhea is a clue for carcinoid tumor. Please remember, because of chronic diarrhea, he has gone for creatinine pre-renal failure. He has gone for pre-renal failure. So who will have a chronic explosive watery diarrhea means it is carcinoid tumor. No, the question clue is diarrhea. Just will not have diarrhea. So please remember, in these four guys, who will have diarrhea you should think of. Carcinoid tumor only will have diarrhea. Carcinoid tumor is most common in appendix. It is most common in appendix. It is a neuroendocrine tumor. It is a neuroendocrine tumor, most commonly seen in appendix. It produces hormones like serotonin. Please remember, serotonin, histamine, all these are produced by these guys. Because of serotonin, they have explosive diarrheas. Explosive diarrhea, continuous severe diarrhea will be there. They will have flushing of the skin. So probably they would have given some other clue, but I didn't get the perfect question. No, so might be the recalled person would have missed the question. So explosive diarrhea, flushing of skin, bronchospasm, right heart failure, pellagra. All these are features seen in carcinoid tumor. So in such case of carcinoid tumor, they will give you a clue. To come to your diagnosis of clue, they will either mention patient having severe diarrhea, what tumor it can be, patient having flushing of the skin, what tumor it can be, patient having bronchospasm, what tumor, right heart failure involving tricuspid valve commonly, what tumor, Pellagra, what tumor? So these are the features to give you a clue. This can be a carcinoid tumor. So not the EUS, investigation of choice for carcinoid tumor is very important. You should know the new scan, DOTA-TATE scan is the latest investigation of choice to locate the carcinoid tumor. Investigation of choice to locate is by DOTA-TATE scan. Diagnosis by means of measuring 24 hours. This question is FMGE question. 24 hours urinary 5-hydroxyindole acetic acid is the answer to diagnose this tumor. How will you diagnose carcinoid tumor? 24 hours urinary 5-hydroxyindole acetic acid. It is a end product of serotonin. 5-hydroxyindole acetic acid is a end product of serotonin. Then this question comes, I am seeing every time the students go and mark wrongly 24 hours urinary VMA. Where will you use VMA? It is used in pheochromocytoma. So please don't get confused with the pheochromocytoma and carcinoid tumor. Carcinoid tumor, it is 24 hours urinary 5-hydroxyindole acetic acid. Okay, it is 5-hydroxyindole acetic acid. Urinary VMA for pheochromocytoma. Both are 24 hours urinary. Please don't get confused in the exam. Okay. See again, 2021, the same question has come. An elderly woman who had history of not taken food for past few days now presented with the bilious vomiting. Her X-ray is shown below. So this is looking like a, what pattern is this? The moment you see the image, you can say what is this case? This is a case of step ladder pattern. Step ladder pattern of obstruction is seen when the obstruction is seen in the distal bowel here. Not here. If there is an obstruction here, there won't be multiple air fluid level. If there is an obstruction in the distal bowel, there will be distal bowel will have this type of multiple air fluid levels. Distal obstruction in the small bowel will cause this issue. Please remember, this is a distal obstruction in the small bowel is causing this multiple air fluid level. So 24 hours metanephrine and VMA both are for pheochromocytoma only. Vinyl mandelic acid, metanephrines, all are plasma metanephrines. It is plasma metanephrines are for pheochromocytoma. Okay. So please remember, vinyl mandelic acid is very important point. So distal obstruction is the correct answer here, not the proximal obstruction. Proximal obstruction, we will have only 1 or 2 bubbles, not this multiple air fluid levels. Okay, simple question. 23 years old female who had every clinical question, first of all, you should not get tired of reading the question. You should not go with the fear that you may not know this clinical scenario. That is second thing. You should not go with the fear, oh, this clinical scenario, don't know what is going to be there. Every clinical scenario question, you should approach just like approaching a small puppy. Don't approach as if you are going to face a gladiator. Just go very casually. Definitely you will know the concept. Definitely you know the answer. When you go without any prefixed bias of fear that I will not know this question, you will definitely answer the question. You let us see what happens in this question. 25 years old female who had pain in the right iliac fossa. Please remember, right iliac fossa. What is that? Right iliac fossa? Appendix is there. She was having vomiting. Was managed conservatively. She was stable for 2 days, after which she had worsening of the symptoms, for which extraperitoneal drainage was done by ultrasound. What is the diagnosis? So probably this girl was having a acute appendicitis which has developed an abscess, for which the radiologists have done a ultrasound guided drainage. So this is a case of appendicular abscess. Simple. If you just think it logically, definitely you will answer. So ultrasound guided abscess. It's a drainage by ultrasound guided appendicular abscess. So the answer is appendicular abscess, not cholecystitis. Why should you go for cholecystitis? Where is it? It is in the right hypochondrium. You will get a pain in the right hypochondrium. Why should you get a perinephric abscess? Perinephric abscess will not get a vomiting and all. They will have fever so severely. So they are giving clearly vomiting, pain. So what is Murphy's triad? Can you tell me what is Murphy's triad? Murphy triad is pain, vomiting, fever. This is the classical 3 features of appendicitis. Pain, vomiting, fever. So classically question on appendicular abscess. What is the site of maximum pain in acute appendicitis? Maximum pain in acute appendicitis is in the appendix point. What is that point? The medial 2/3 and lateral 1/3. This junction, this point is known as McBurney's point. They may ask you what is McBurney's point. Please remember, medial 2/3, lateral 1/3 is McBurney's point. So McBurney's point is medial 2/3, lateral 1/3. That is a point of maximum tenderness. So appendicular abscess, we don't do Aschner-Sharon regimen. Aschner-Sharon regimen is a conservative regimen for appendicular mass. For appendicular mass, we do a regimen known as Aschner-Sharon regimen. So please don't forget, Aschner-Sharon regimen is a regimen used for appendicular mass. So this question was just now I am telling you. There is a question on barium image showing you an appearance like this. What is it? It is a sawtooth appearance. Sawtooth appearance is shown in the image. Please don't forget, it is a sigmoid diverticulosis. Simple, straightforward question on sigmoid diverticulosis, a sawtooth appearance. So these are recent questions. FMGE June 2021, we had a classical specimen image. Now they are asking specimen in questions. So this is a specimen of colon. If you see, this is, they gave a specimen of colon having hundreds of polyps like this. Who will get hundreds of polyps like this? So it is seen in familial adenomatous polyposis. APC gene 5q chromosome mutation, adenomatous polyposis will have this multiple polyposis. So please remember, APC 5q chromosome mutation will have this thing. And what is Gardner's syndrome? Gardner's syndrome is a syndrome associated with FAP. FAP plus sebaceous cyst in your body. You have sebaceous cyst plus exhastosis in your bone, plus you have retinal pigment in the pigment retina. Now you get pigment deposits. Retinal pigments will be seen. So that is known as Gardner syndrome. So familial adenomatous polyposis is characterized by 5q mutation, autosomal dominant. It is associated with the Gardner syndrome, FAP, sebaceous cyst, exhastosis, and retinal pigmentation. So these cases will need a prophylactic total proctocolectomy because they definitely will develop colon cancer. So we have done a prophylactic total proctocolectomy, means we remove the entire colon, rectum, everything, and we will do a ileal pouch anal anastomosis. We do the anastomosis of the ileal pouch with the anus so that they won't develop a cancer. So this is a surgery done for them prophylactically. Even before the cancer happens, we do total proctocolectomy with ileal pouch anal anastomosis. 70 years elderly male. Presence on rectal examination, a mass was found suspicious of cancer. He had normal bowel habits. He actually visited to your hospital for a master health checkup. So please remember, 70 years male was found to have a cancer. He had normal bowel habits and he actually visited to your hospital for a regular master health checkup. What will you advise him next? What will you advise him next? So the advice will be done for him will be on, we suspect is a cancer. So please remember, there is a cancer in the colon. What do you do next? I want to know whether it is a cancer or not by doing a perirectal examination. First I will do a perirectal examination. After doing perirectal examination, if I suspect cancer, I will go for next step will be to do a small flexible sigmoidoscopy and take a biopsy first. So immediately the same day I will do a flexible sigmoidoscopy and do the best. But what will be the best for him? They are not asking next and best. Next will be put a tube, take the biopsy and come out. Best will be I should rule out the entire colon whether there is any other cancer. Many times the patients will have other cancer. This is a cancer here. I will put a scopy, take biopsy, and best is I will go and see full colon and take any other biopsy. So the best answer is colonoscopy and biopsy. Next answer is flexible sigmoidoscopy and biopsy. There is a difference between next and best. So next is the one which can be easily done and can be done next minute itself. Best is the one which needs some preparation. We have to prepare the patient with a piglet solution. We have to wait and do that. So that is best. 5 years old baby having constipation. We are giving stool softeners also, but is still able to pass only stool once in a week. There is a history of passage of meconium after 48 hours of birth. What investigation would you do initially in this baby? Simple question. Especially baby. So what is your diagnosis from this question? This baby is having constipation. A baby not passing motion. What do you think will be the answer? Okay, what is the answer for that? Baby not passing motion will be probably a case of Hirschsprung disease. So in this question, if you know the diagnosis, Hirschsprung disease, if you know the history, you can definitely confirm the diagnosis. So Hirschsprung disease, this is a case of aganglionosis. Please remember, this is a case of aganglionosis. So aganglionosis. This is a case of aganglionosis. Aganglionosis of the rectum will cause this Hirschsprung disease. Therefore, the investigation of choice to diagnose Hirschsprung disease is rectal biopsy. So please remember, investigation of choice is rectal biopsy. Rectal biopsy. But this question again the same problem. I'm saying, I'm telling the students in clinical question, they get more problem with the next and the best. So what is the next thing should be done in this case? This baby is, we are suspecting a disease known as congenital megacolon. So congenital megacolon, I can just like that find out, I can suspect it by taking an X-ray, abdomen erect. So abdomen erect I can take and confirm the diagnosis. That will show you distended dilated colon. So the next done, or what will you do initially is plain X-ray of the abdomen will be done initially. Simple question. So plain X-ray of the abdomen will be done initially, and the investigation of choice will be rectal biopsy. Okay, the gold standard will be rectal biopsy. So the same question, what will you do next? What will be the best? So here the question is asking what will you do the next? If they would have asked what is the best investigation, I would have gone for, if the choice was there as rectal biopsy, I would have gone for that. But they have not asked the rectal biopsy. They have asked only the initially done plain X-ray will be done. Okay, plain X-ray will be done is the question in this. Yes, there will be dilated colon. Okay, we can see the dilated colon. Yeah, we can see on X-ray the dilated distended colon. We will have a clue. After that, we will proceed for the definitive investigations. Okay, we will do even barium minima, anorectal manometry, everything can be done. CT also can be done. But what is done initially? The question is asking what is done initially. Same question. See, February, December 2021. The same question. Corkscrew esophagus. You can see the answer is diffuse esophageal spasm. So once you see the 2 years paper, everything is same. So this is diffuse esophageal spasm. This problem of investigations will come for you only in surgical gastrotopic, gastrointestinal tract. In other places, you will not get this confusion. Only in GIT, you will have this type of confusions. Okay. Patient is having retching pain, vomiting, retrosternal pain, most likely causes. So patient is having retching pain, vomiting and retrosternal pain. What do you think this is? Patient is having a retrosternal discomfort. That is a clue. If we all would have had that retrosternal pain, and sometimes may even vomit, and we may even have a retching pain. So this is usually a case of pyloric stenosis. So pyloric stenosis here, it is a pyloric stenosis here. There is an obstruction here. So therefore the food is unable to go down. They are coming and reflexing and causing this problem of esophagitis. Esophagitis will also happen like this, but this pyloric stenosis causes vomiting plus esophagitis. That esophagitis causes retrosternal pain. If the question was asking only, the question is only asking about retrosternal burning, I would have gone for esophagitis. But the question is giving a classical history, retrosternal pain, vomiting and retching pain. So that is most probably a case of pyloric obstruction. It is mostly a case of pyloric obstruction. Yes, esophagitis causes retrosternal pain, but esophagitis will not have retching pain and vomiting. So retching pain, vomiting is more in favor of a pyloric stenosis. Okay. Peptic ulcer will not cause retrosternal pain. That is easily excluded. Intestinal obstruction is also easily excluded. They will have severe abdominal pain only. Peptic ulcer will have pain in the abdomen, not in the chest. So the chest pain is due to repeated reflex from the pyloric stenosis. Okay. So this is a simple question. On a lateral view, a child had a difficulty in gobbling, means unable to shout. The baby is trying to shout, but she was unable to shout. He was able to speak, but unable to shout. She is telling there is something obstructed. Identify the site of foreign body shown in the image. This is a classical question. You have to identify the site. This is actually a radiology question, not my question, but just I wanted to put it here. In this picture, what is this anterior structure? What will be here? What is this anterior structure? Where you think this foreign body is located? The baby has swallowed a 1 rupee coin. For example, this baby has swallowed a 1 rupee coin. Where is the coin? There are two routes for entry inside. Either it can enter into the trachea or it can enter into the esophagus. The question is, where is it now? The question is, where is it now? If it is in that, this is trachea. You can see the gas shadow. Can you see the tracheal gas shadow? So therefore, it is not in the trachea. What is there behind the trachea? It is esophagus. So it is seen in esophagus. It's a foreign body in the esophagus. So this question is very classical question. Where is the foreign body means? It is in the esophagus. Okay, so just an image based question. A patient underwent total gastrectomy. Which of the following deficiency will be seen? So which deficiency is common in a gastrectomy? What is produced in the stomach? Stomach produces intrinsic factor which is needed for absorption of B12. So it's again a simple question from applied biochemistry, applied physiology. There is a vitamin B12 deficiency seen after gastrectomy. We have to supplement them with B12. Okay. The inner opening of anal fistula usually begins at. So in an inner anal fistula, I told you this is the anus and this is the opening from inside to outside. The outer opening we can see by naked eye, but inner opening where it will begin means it will be seen at the crypts at the dentate line. Dentate line, no, the dentate line there will be cryptoglands. Those glands get abscess and that forms the fistula. So it will be seen at crypt at the dentate line. Some questions are, when these questions are they are a little tough questions, but once you have read in depth about fistula, you will answer this. If you are a NEET PG aspirant, definitely you would have read this. It arises from crypt abscess. That's the line. Fistula arises from crypt abscess. So that is from the crypt at anal dentate line. Okay. So this again another question, same question. See, female who was taking NSAID for long time period of arthritis presented to emergency with abdominal pain. Abdominal radiograph shows this finding. See again the repeat question. It is a pneumoperitoneum. It is a pneumoperitoneum perforation of peptic ulcer. Same which is causing air under diaphragm. Just now I discussed, same question is repeated. Air under diaphragm, same question repeat. So this is the first time asked new question. It is directly taken from Bailey and Love. There is an image there. This image is there in Bailey and Love. Okay. What do you think this investigation is? So many surgery and radiology questions will be overlapping. Most of the surgery, radiology questions related to surgery will be there in Bailey itself. Okay. Very good, Gayatri, very good. So what is this investigation shown below? This is a picture showing you the bowel. Inside the bowel there are some fluid which is looking like a black one, and the bones are all not so prominently seen. If it is a CT scan, you can see the bone as hyperdense. So this is MR enteroclysis. MR enteroclysis, in which the bone will not be seen as prominent. So this question is a simple radiology question, MR enteroclysis. Okay, MR enteroclysis. How to know this MRI or CT is based on the bones. You have to see for the bone shadows. In a CT scan, you know very well the bone will look very bright. Okay, here it is MR enteroclysis. I think this is the last question in this chapter. Lady is in the first trimester of pregnancy, presents to emergency room with acute abdominal pain. She is diagnosed to have acute appendicitis. Next step is, so in pregnancy or not in pregnancy, acute appendicitis, answer is appendicectomy. Simple question. I don't know why students got confused in this paper and made it wrong. Many students made it wrong in this picture. So please remember, appendicectomy is a treatment for any appendicitis, anybody. Whoever is that, the treatment is acute appendicitis. We have to go for appendicectomy for all pregnant patients. First trimester of pregnancy or even second trimester, third trimester, whatever it is. If there is appendicitis, we have to do appendicectomy. The problem is they may go for abortion. So the more chances of abortion is there in such patients. A patient suffering from inflammatory bowel disease presented with a peritonitis. It's a case of inflammatory bowel disease like ulcerative colitis presented with peritonitis following ileal perforation. Maybe an ulcerative colitis or Crohn's disease. Exploration is done. You as a doctor would prefer to do which of the following now. So the patient is in peritonitis. I will not go for a perfect procedure at this point of time. I will just like that take the ileum out and do a ileostomy and plan definitive surgery later. Simple question. So we will not do any anastomosis. Simple concept here is we won't do anastomosis at this point of time. This patient is in peritonitis. I cannot do an anastomosis. If I do anastomosis, that will lead patient will die. Simple. Answer is ileostomy and definite surgery later. So that there you can see GIT is given among the 5 sections I am discussing. So I am discussing 5 sections. We have discussed general part on that day. Second trimester also we have to do surgery. So I have not told second trimester we will do appendicectomy. It is not an elective case. Any elective surgeries if you want to do, you can do in second trimester. Emergency case, whenever it comes, it's an emergency. It is not an elective case. Okay, you have to do it whenever it comes. So there is no elective case. Okay, so patient with a peritonitis following ileal perforation, exploration is done. You as a doctor would prefer to do which of the following? Means it is ileostomy and definitive surgery later. So you can see gastrointestinal tract, we had enormous number of questions, like around 57 questions we had in this GIT. So among various sections, that is highest among all. So now we are going to the hepatobiliary and pancreatic and splenic organs. Most common immediate complication of splenectomy is. So most common immediate complication. The question is not asking what is the most common complication overall. There are two questions. Most common complication overall is left lung atelectasis. Simple question. This is the very commonly asked PG question. What is the most common complication of splenectomy? So it is left lung atelectasis. Please remember, it is left lung atelectasis. Most common immediate complication of splenectomy is hemorrhage, bleeding. That is the most common immediate complication. So you might have tied some vessels, that vessel would have bleeding. So that is the most common immediate complication of splenectomy. So the most common immediate complication is hemorrhage. Okay. Most common overall complication is left lung atelectasis. So abdominal pain, fever, jaundice. 100 times asked FMGE question. This triad is known as pain, jaundice, fever. This is a triad of Charcot's. Okay, please don't forget. This is a triad of Charcot's seen in cholangitis, infection of the biliary system. It is seen in cholangitis. So pain, jaundice, fever plus shock plus mental changes. Mental changes. What is it known as? It is known as Reynolds pentet. Reynolds pentet. So these are very dangerous complications which is seen in cholangitis. Pain, jaundice, fever is Charcot's triad. Shock and mental status changes is Reynolds pentet. So this is a question asked in the exam. From the image you can see this is a opened up gallbladder. Opened up gallbladder. You can see the lesion here. It is a carcinoma of the gallbladder. So it's a carcinoma of the gallbladder showing you a lesion. It's a tumor. Tumor is seen in the gallbladder specimen. So they can ask you the specimen of gallbladder with the gallstones or with the cancer, something they will be definitely asking you. So this is looking pakka like a cancer. So there is one more question asked in NEET PG which looked like a strawberry, The gallbladder is looking like a strawberry like this. That is known as cholesterosis. The entire gallbladder was studded with small stones and the gallbladder was looking on cut section like a strawberry gallbladder. Strawberry gallbladder is cholesterosis. It is asked in 2022 NEET PG exam. So you can highly expect this question again. So this is a question on tumor. This is a question on cholesterosis. Okay. 5-year-old boy presented with multiple episodes of hematemesis. So question is going to be asked on hematemesis. He was vitals are stable. Splenomegaly is noted. Mother tells at the birth the boy had developed jaundice and an exchange transfusion procedure has been performed in the same hospital. What is the diagnosis? So this guy is probably having a problem with the vascular issues. There is a problem in the vascular issues. So this case is very commonly portal vein thrombosis. So extrahepatic portal vein obstruction presents with hematemesis plus splenomegaly. Why there is a hematemesis? Can you tell me why there is hematemesis in EHPVO? Can anybody tell me why there is hematemesis in EHPVO? It is because of what reason? Varices, esophageal varices. These because portal vein is obstructed. No. So they develop therefore collaterals that forms hematemesis. So it's portal vein thrombus. Actually the name is EHPVO, extrahepatic portal vein obstruction. You will be reading in pediatric. This is a case of extrahepatic portal vein obstruction. They present with hematemesis and splenomegaly in less than 10-year-old. Less than 10-year-old will present with hematemesis, splenomegaly, esophageal varices. If the same question was given as at 25 years, I would have gone with another disease, that is non-cirrhotic portal fibrosis. So both are same, but small difference. If there is an obstruction of the major veins, there is an obstruction of the major veins, that means it is EHPVO. If there is obstruction of smaller portal veins, smaller branches of the portal veins, it is non-cirrhotic portal fibrosis. So in a case of the point here, the boy developed jaundice and exchange transfusion was done is a clue to tell you he might have had an umbilical sepsis. So umbilical sepsis was there at that time. So following which he might have had a jaundice, and umbilical sepsis is a cause for EHPVO. That might be a reason, but other than that, the question is very clear from the first line itself. It is it's extrahepatic portal vein thrombus or obstruction. So this is a simple question showing you a water lily sign. Actually, it was not given in the exam as water lily sign. I noted it in the question. Patient with the right hypochondrial pain sign. Pictures shown here. What is the diagnosis? It is a picture of water lily sign. So I would like to tell you some ultrasound pictures will be asked in your exam. Number one, ultrasound picture for your exam is in the right hypochondrium. If there is a stone, what finding will be there in ultrasound? If there is a stone in the gallbladder, the finding will be this is posterior acoustic shadowing. Posterior acoustic shadow. It is a finding seen in gallstones. So this question will be definitely asked for your exam. In the right iliac fossa, appendix ultrasound image was asked. Appendicitis. It will be thick, non-compressible appendix. Non-compressible tubular structure is appendix. So that is also asked in the exam. And this is another thing which is asked in the exam, which is nothing but hydatid cyst. Hydatid cyst will have water lily appearance. So it is having a water lily appearance. So please remember, it is hydatid cyst which is showing you a water lily or a water snake appearance. So please don't forget, these three ultrasound findings are commonly asked in your exams. So see, now just now the next question is coming. A pregnant lady on routine ultrasound shows following finding. What is your diagnosis? So you can see in this question, there is a stone which is showing you posterior acoustic shadowing. There are small stones which are showing posterior acoustic shadowing. These are gallstones, multiple gallstone image is a very favorite question of National Board examiners. So if there is a polyp, you can see if this is a gallbladder containing a polyp, the polyp is differentiated from stone by simple way. There is no posterior acoustic shadowing. If it is a stone, there will be a acoustic shadowing. It's a very simple difference between polyp and gallstones. 3 days after cholecystectomy, patient developed a severe abdominal pain with fever. Her LFT was normal. Serum amylase was also normal. What is the most likely cause of her condition? So 3 days after cholecystectomy, patient developed a severe abdominal pain and fever. LFT was normal. Amylase was also normal. So what is the most likely cause of her condition? What is the most likely cause of her condition? Patient is having, thank you Raj. So patient having abdominal pain, fever, LFT normal. Amylase was also normal. Why they are telling amylase? One question is ruled out. Pancreatitis is ruled out. So if there is amylase increased, it is pancreatitis. So ruled out pancreatitis. So LFT is normal. So LFT is normal means CBD stone is ruled out. LFT will be elevated if there is a CBD stone, they will have jaundice. So patient is now after 3 days of cholecystectomy, patient develops abdominal pain and fever. Answer is bile leak. It cannot be an abscess. Yes, it can be an abscess, but not very important here. This is a patient who has done a cholecystectomy. So post cholecystectomy, patient will develop a leak from somewhere in the bile duct. That will only cause pain and fever. Yes, post cholecystectomy they may have a bile duct stone. That is ruled out by LFT normal. They can develop pancreatitis. That is ruled out by serum amylase normal. So every word mentioned in the question will be leading you to some one answer to excluding the other answers. Sometimes you can come to the correct answer by excluding the wrong fellows. Okay, here I have coming to bile leak. A lady was incidentally diagnosed with a 0.5 centimeter solid mass in her gallbladder and ultrasound, which was non-mobile, diagnosed as gallbladder polyp. She is asymptomatic. What is the next step? I am telling you, the moment you start your practice, you are going to see enormous patients coming to you with ultrasound report showing you gallbladder polyp. So we don't operate all the gallbladder polyps. Please remember, gallbladder polyp will be operated when it is more than 1 centimeter size. First point. When it is more than 1 centimeter, I will operate. Or increasing size. Every 3 months once, I will be doing repeat test. Increasing size, I will operate. Number 2, I will operate when it is further increasing. Number 3, when the gallbladder polyp has associated stone, I will operate. history of gallbladder cancer I will operate. So please remember, when will you operate a gallbladder polyp? When it is more than 1 centimeter, increasing size, polyp with stone, gallbladder cancer I will operate. Simple question. So it is 0.5 centimeter. So I won't operate. Reassure the patient and follow up the patient. So once you remove the gallbladder, what do you expect in a lady after gallbladder removal most commonly? So very common point you should remember here is, what is the function of gallbladder? Gallbladder is going to store the bile salts and they are going to get concentrated in the gallbladder. And once the patient is eating a fatty food, that fatty food, when it enters the duodenum, that is going to be digested by this bile salt. So now I don't have gallbladder. So I have done a cholecystectomy. Now when I am eating a fatty food, the bile salts will not be sufficient to digest the fatty foods. So I may have a steatorrhea for few months, not always. Steatorrhea may be seen for few months. It is not a permanent problem. Slowly the bile duct will adapt and they will be digested. So temporary steatorrhea, it is not a permanent steatorrhea. Temporarily they will have steatorrhea after gallbladder removal. Miss X, 35 years old, presented with emergency with upper abdominal pain radiating to the back. So the catch point is here. X-ray shows colon cutoff sign. What is the diagnosis? Simple question on colon cut. These are all, I'm telling you, many of the FMG questions are actually one-liner questions of 5 years back, 10 years back. All those one-liners questions, they found out these FMG guys are just mugging up the one-liner questions and they are answering the questions and getting passed. So the National Board examiners, they wanted to make most of them fail. So they decided to make all the one-liner questions into clinical questions. Therefore, every clinical question will have that same one-line point everywhere. That is a colon cutoff sign. That is pancreatitis. Okay, that is acute pancreatitis. The findings are colon cutoff sign, gasless abdomen, sentinel loop sign. All these are findings seen in X-ray of pancreatitis. In X-ray of pancreatitis, you will see all these signs. Okay, so please don't forget acute pancreatitis clinical. Find the clinical sign is very interesting. That is Mohammedan prayer sign, Killians sign, Grey Turner sign. I hope you all know these signs. These are very basic signs. Grey Turner sign is pigmentation in the loin. Killian is U for umbilicus, in the umbilicus. Grey Turner is in the lumbar region. Mohammedan prayer sign is they will sit like a namas method. Okay, like Muslim doing prayer, they will be sitting because of intolerable pain. So these are the various signs you should know in acute pancreatitis. A patient has an ultrasound finding of gallstone abutting the cystic duct. Very interesting question. So this is a question on simple diagnosis. There is a stone in the gallstone which is abutting the cystic duct, which is compressing the bile duct. See, with the dilatation of the common. So therefore the duct is also dilated. What is this syndrome known as? Simple question. A stone in the gallbladder compressing the bile duct is known as Mirici syndrome. They will have jaundice. Yes, Vincent, very good. Fox sign is sign in inguinal ecchymosis, inguinal region. Okay. Investigation of choice in acute pancreatitis is CECT, not ultrasound. Ultrasound is not the investigation of choice. CT is the investigation of choice. So this is a classical question on Mirici syndrome. Please don't forget, in Mirici syndrome there will be stone in the gallbladder compressing the bile duct. Simple question. Okay. Identify the condition shown below. Diagnose the condition shown below. You can see from the image, there is pancreas encircling the second part of duodenum. Annular pancreas will have double bubble appearance. Same like duodenal atresia, they will also have double bubble appearance. So annular pancreas, simple question. From the image you can find out what is it. A female with epigastric pain and right hypochondrial pain radiating to the back and guarding and rigidity in the right, you have to know where is the pain. Guarding, rigidity in the right hypochondrium. What organ is there in the right hypochondrium? Gallbladder. She had similar episodes in the past 1 year. So right hypochondrial pain, from here it is radiating to the back. It is a classical case of acute cholecystitis. The sign we get is Murphy's sign. Okay, Murphy's triad is for appendicitis. Murphy's sign is for cholecystitis. So a patient presents with a pain in the right hypochondrium. Blood investigation shows AST 221 increased. Aspartate transaminase 22. It's normal. Okay, normal. Alanine transaminase normal. Bilirubin is increased 5 milligrams. Alkaline phosphatase increased. What should be the initial investigation? Simple question. So for a biliary system, so there is a question on biliary pathology. Any biliary pathology, what is the first done investigation? Can you tell me? First done is ultrasound. First done is ultrasound, no doubt in that. First done is ultrasound. If gallstone is shown, gallstone, investigation of choice is ultrasound. If CBD stone is seen, what is the investigation of choice? It is MRCP. MRCP for CBD stone. Gold standard for CBD stone, it is ERCP. Please remember, why? Because I can remove the stone by ERCP. So please don't get confused. Ultrasound will show you some problem. What problem? Gallstone. Investigation of choice, ultrasound is enough. CBD stone is shown, investigation of choice, MRCP. If you have a doubt, acute cholecystitis is seen. Acute cholecystitis, investigation of choice is ultrasound. What is the gold standard for acute cholecystitis? Gold standard. NEET PG question, very commonly asked NEET PG question, it is HIDA scan. HIDA scan is a gold standard for acute cholecystitis. Gold standard for acute cholecystitis, HIDA scan. But investigation of choice is ultrasound. In HIDA scan, the finding will be non-visualization of gallbladder. Gallbladder will not be seen. That is the edema of the gallbladder causes non-visualization. That is HIDA scan. So please remember, HIDA scan is used only for doubtful cases of acute cholecystitis, not for all cases. Okay. So 30-year-old female presented with sudden onset of central abdominal pain radiating to back. This is central abdominal pain. So previously I told you this question is very catch point question. If a patient is having pain in the please remember, right hypochondria radiating to back is acute cholecystitis. If a patient is having pain in the center of the abdomen radiating to the back is acute pancreatitis. Simple difference. So right hypochondrium, cholecystitis, central of that is a pancreas here. That is a place of pancreas. So that is acute pancreatitis. Please remember this question. Okay. Identify the operation shown. Last year question. Identify the operation done in this case. What is the surgery? This question you should be thorough. This is a case of pancreatic cancer for which Whipple's operation is done. Whipple's operation is done for a pancreatic cancer. In my YouTube channel, I have uploaded the video of Whipple's operation. Simple 1-minute video I have made. Please understand what is Whipple's. This is the normal anatomy I am drawing. First of all, to make you understand the Whipple's operation. So this is pancreas, this is pancreas, this is bile duct, gallbladder, this is the hepatic duct. So now where will I do this Whipple's operation? I will do this Whipple's operation for cancer in the pancreatic head. Please remember, pancreatic head or distal CD or in the ampulla. Any cancer in these 4 places. So anywhere in this place, if there is a cancer, what I am going to do? I am going to remove the following structures. I will remove the distal stomach, entire duodenum, pancreatic head, bile duct and gallbladder. So therefore the remaining structure is these 3. So stomach, pancreas, bile duct. So what I will do? I will bring this jejunum and do the anastomose like this. So this is a 3 anastomoses: pancreatic jejunostomy, gastrojejunostomy, hepatic jejunostomy. This is Whipple's. So please remember, Whipple's is highly expected MCQ you can get in exam. Specimen of Whipple's. So this is again another favorite question of National Board examiners. Whenever an alcoholic male, this word is very important, alcoholic male presents with epigastric region radiating to back. So it is a case of pancreatitis. Now pancreatitis has developed a complication. That cyst is seen behind the stomach. And you see, this is stomach. This is a pancreas having a cyst. This is pseudocyst of pancreas. So pseudocyst of pancreas, you should not forget. Pseudocyst of pancreas is this, seen behind the stomach. Pseudocyst is most commonly following a acute pancreatitis or chronic pancreatitis. It is usually seen following a pancreatitis. They will present to you with a epigastric mass. Epigastric mass will be present. Treatment is, this is the stomach and this is the cyst. I will do surgery and drain it into the stomach, known as cystogastrostomy. The treatment is cystogastrostomy. That's all. Only 17 questions were asked in the past 3 years from hepatobiliary and pancreatic. Very less number of questions. So therefore, if you see, In GIT, the focused areas, I can tell you the organs, focused areas, number 1, achalasia cardia, focused area number 2, corkscrew esophagus, Bird's beak achalasia, corkscrew esophagus, Bohr syndrome, Mallory Weister. Simple, 4 topics in esophagus. Few questions are asked from esophageal cancer, and in stomach, the most important question is congenital hypertrophic pyloric stenosis and perforation of the duodenal ulcer. In bowel, ulcerative colitis, Crohn's disease, ileocecal TB. In anus, perianal fistula, pilonidal sinus. That's all. Within this 10 topics only, the chapter will be rolling on. The questions will be continuously being asked. And in hepatobiliary, it is question always from acute cholecystitis, acute pancreatitis, and from some images of gallstone. That's all. We can differentiate it from the history. I'm telling you, you should never ever see the image. Even if it is a radiology question, never see the image. You only should see the question. Then only you should go to the choice reading. Yes, it can be a hydatid cyst. If you don't read the question, you will answer as hydatid cyst. Because hydatid cyst, why should they mention an alcoholic male? Why should they mention radiating to back? Hydatid cyst will have no pain. It will be painless. Pseudocyst will have pain. Number 1. Number 2, alcoholic is not a clue for hydatid. What will be the clue for hydatid? The clue for hydatid will be a person having a dog in his home, sheep in his home, the sheep died or the dog died, that fellow now come, that will be a history. The history of hydatid cyst will have history of dog or sheep in his home. Simple. And please remember, hydatid is painless. It's painless. Okay. So now I am coming to one of the important small topic, but so many questions. It is from urology. So 40-year-old man is suffering from heaviness in the scrotum. I am telling you, for Indian exams, for Indian exams, if a final year student is appearing for the exam, no boy or no girl can come out of the exam hall without touching the penis and scrotum of a patient. That means that much number of cases are there only from inguinoscrotal region. Either it can be hernia, it can be an hydrocele, it can be some architis, it can be varicocele, some problem from the testicular area or from the penis area or from the inguinal area will be commonly kept in Indian exams. So for any Indian student, if any question is asked from these areas, they will answer it without any hesitation. That much they would have seen so many number of cases from the inguinoscrotal region. So therefore you should never have a doubt in any of the inguinoscrotal disease. Simply you should answer within a fraction of second any topic from these areas. Okay. So 40-year-old male having every word, every topic will have a catch point. Bag of worms is observed on scrotal examination. So the swelling disappears on supine position. What is the diagnosis? What is the diagnosis? The diagnosis is varicocele. Varicocele is a dilated tortuous veins in the scrotum. So it is a varicocele. The treatment is varicocelectomy. That's all. Varicocelectomy is the answer for these questions. Okay, varicocele. So I'm telling all the questions are being asked in FMGE exam. All the scrotal diseases are asked in the exam. Identify the abnormal condition given below. Can you tell me what is this condition? You can see here. This case is having this is a normal spermatic cord, but here you can see dilated worm-like structure. Worm-like structure. What is it? So worm-like structure is a varicocele. It's a varicocele. So worm-like appearance in the scrotum. If you palpate, there is a worm-like structure. It is varicocele. If it is a testicular torsion, usually they will give you both side testis. Please remember, if they are going to ask you a testicular torsion, the image will be like this. So this will be one side testis. Another testis will be lying higher up like this, and there will be a coiling like this. So one testis will be higher up. So they will give a comparative image of torsion. So torsion will be given a comparative image. Varicocele will have bag of worm-like sensation in the scrotum. Okay. Prostate cancer mostly seen in which lobe? It is an applied anatomy question. So posterior lobe. Please remember, posterior lobe is common to get a cancer in prostate. It's an anatomy applied question. Just remember, posterior lobe gets cancer. Median lobe gets BPH, prostatic hyperplasia. But we surgeons never use the term lobe at all. We use only the terms known as zones. Peripheral zone develops cancer. For us, what zone develops cancer means peripheral zone develops cancer. So transition zone develops BPH. So this is surgery question actually. When the question is asked as zones, it is a surgery question. When it is asked as a lobe, it is an applied anatomy question. So posterior lobe is cancer. Peripheral zone is cancer. I will tell you easy method to remember. If it is a cancer, it is seen in P and P only. Posterior lobe and peripheral zone only. Please remember. It can be a peripheral zone or a posterior lobe only. The cancer will be seen. Remember this question. Early investigation for genital TB. If you are having a genital tuberculosis, what will be the most common symptom of genital TB? Can you tell me? What is the most common symptom of genital TB? No, Raj Gautam, the varicocele is not always because of renal related problem. Left side varicocele not reducing on lying down. Please remember, this is a very interesting, nice question from Raj. This is an IVC. This is IVC. This is left renal vein draining into the kidney. Okay, the left renal vein. So this is left renal vein. This is right renal vein. So left testicular vein will drain into the renal vein. Right testicular vein will drain into the IVC. So point you should remember here is, this is the testis, this is the testis. Varicocele doesn't mean there should be a problem in the renal vein alone. It can be happening because of defect in the valves or some other reasons also. But if there is a cancer, renal cell cancer infiltrating into the left renal vein, this fellow will develop a varicocele which will be irreducible. That is a classical MCQ point. Irreducible varicocele is seen in left side RCC. Please remember this. In our question it is reducible, so it is not a confusion. It is a normal varicocele. Right side RCC will not cause right side varicocele because this vein directly drains into IVC. Simple point. Right side directly drains into IVC. Why should I develop an obstruction? But left side RCC is due to irreducible varicocele. Okay, that's a very important point. Should not forget. Simple question. Very favorite final year clinical viva question. Yearly investigation for genital TB. The most common symptom is very good, Armit. That is increased frequency of micturition. This fellow will go for urine every 1 hour, 2 hours. Once the fellow will be going for urination. Urine culture will be normal. You will have no urinary infection. When you do the urine test, that will show you sterile pyuria. Sterile pyuria. No bacteria there in the urine, but he will keep on going to the urine again and again. Sterile pyuria means WBC is present, but no bacteria present. So therefore, what should I do? Early morning urine sample for AFP will be done. So I will do a early morning AFP specimen. So many questions from urology. I am telling you, around 15 to 20 questions came from the urology. In each paper we got around 3 to 4 questions. Thimble bladder means contracted bladder. Where will you get? Contracted small bladder seen in chronic TB. And this ureter known as golf hole ureter. Golf hole ureter, putty kidney, golf hole ureter, thimble bladder, all are features of chronic TB. Please remember, not acute TB. Chronic TB will cause all these problems. From the question you can see, they are more focused towards any problem in the tuberculosis because it is an Indian disease. It's very common in India. So as you are foreign medical graduates, they expect you to know everything about the Indian disease TB. Okay, putty kidney, golf hole ureter, thimble bladder, all are features of chronic tuberculosis. PCNL is a latest new treatment for kidney stones. Percutaneous nephrolithotomy. Please understand, this is a ribs and this is hypochondrium. So now what is the latest treatment for any stone in the kidney is, instead of opening surgery like a laparoscopy we are doing, these radiology guys, the urology guys, they will put a scope like this directly into the kidney by a small hole. Through the small hole, by using vision like this scope is known as nephroscope. They will break and remove the stone in pieces through this pathway itself. This is known as percutaneous. You see, percutaneous nephrolithotomy. So percutaneously, they go inside the abdomen, puncture inside, go take the stone and come out. So while doing this, what all problems they can cause? They can injure the colon, yes. They can injure the pleura, yes. They can injure the lungs. Okay, they can injure the lung, yes. They can injure some blood vessel which can cause bleeding. So colon injury, pleural injury, bleeding, everything can happen. What is not seen as ureteric stricture. I am not going to the ureter. I will stop here. I will not go into the ureter at all in PCNL. So PCNL, therefore ureteric stricture is not seen. I can injure the colon, I can injure the pleura, I can injure the lung, I can injure any blood vessel causing bleeding. Simple question on PCNL. A baby, this question is a repeat question. A patient's mother, while bathing a child, noticed there was no testis in the scrotum. And on examination, please remember, on examination, there is no testis, only penis is there. On examination, one testis is seen in the inguinal region like this. And another testis is seen in the perineum. In the perineum, what is the diagnosis? There are two types of testis problem. One is the testis not coming to the scrotum, known as undescended testis. Another is testis going to an abnormal path. An abnormal place is known as ectopic testis. Simple question. So inguinal pathway is a normal pathway of testis. So it is a right side undescended testis, and it is going to the perineum instead of coming to scrotum. It is left ectopic testis. Answer is C. So undescended testis and left ectopic. No, we will go through the. There are two routes. I can go subcostal route or transcostal route. So if I go to transcostal route, I can injure the pleura. So it's through the kidney is seen in this place. We will sometime enter the kidney if the stone is in the upper part through the ribs. Between the ribs, the holes will be made. So we can injure the pleura. Posteriorly, we can injure the pleura. Okay, very common. There are two techniques in PCNL. One is subcostal technique. Another is transcostal technique. In transcostal technique, the pleura can be injured. Okay. So here it is right side undescended testis, left side ectopic testis. 10 years old boy with history of recurrent urinary tract infection. IVP image is given below. Identify the location of insertion of ureter arising from the left superior pelvis. In this, if you have to observe very closely, this is intravenous pyelogram image. Please understand the image. So this is a normal kidney here, right kidney normal. So from the kidney, the urine is coming out through the right side ureter. It is going into the bladder. Okay, you are seeing the bladder, it is going. But in this place, you see the kidney is having two ureters. This is one ureter and this is one ureter. Can you see? Very closely, if you observe, there are two ureters. This is one ureter, this is one ureter. Now the question is asking, which ureter is abnormal? Usually the upper ureter is abnormal, known as ectopic ureter. Please remember, the ectopic ureter is the upper ureter. Where it will go and drain? It will go down. I'm drawing that ectopic ureter. Go down, and it will go and join the urethra, prostatic urethra in males. It will join the prostatic urethra in males. Please remember, if it is a boy, it will join the prostatic urethra. If it is a girl, it will join the vestibule. So very interesting. This rule is known as what? What is the name of this rule? The abnormal ectopic ureter will go down and drain distally is known as Wiegert-Meyer rule. Wiegert-Meyer rule. Okay, this is seen in ectopic ureter. Girls will have paradoxical urinary incontinence. They will continuously have dribbling of urine. They will have continuous dribbling of urine, known as paradox. This question is a question asked in the exam. A young girl was brought to the hospital. She is passing the urine normally, but other times she is having dribbling of urine. Her undergarments are getting soaked with the urine. What is your diagnosis? It's an ectopic ureter opening in the vestibule, paradoxical urinary incontinence seen in these cases. It is also known as duplication of ureter or ectopic ureter. So definitely there is a question on ectopic ureter going to help, and all the IVP images they will get you. So in IVP images, I will tell you what are the IVP images in exam. So where will you get a flower vase appearance like this? Flower vase. Flower vase is horseshoe kidney. Drooping lily appearance. Drooping lily appearance is seen in ectopic ureter. Ectopic ureter getting obstructed will cause this drooping lily appearance. Spider leg appearance. Where will you get spider leg? Spider leg appearance seen in polycystic kidney disease. Polycystic kidney disease. And what is this image showing you? This image is showing you an appearance like a cobra head. Cobra head appearance seen in ureterocele. Ureterocele. Bilateral ureterocele will have a ectopic kidney has an appearance drooping lily. Drooping lily is not a disease. The disease, the ureters looks like instead of they look like this, they look like this down. That is known as drooping lily. The ureters are being the perianal calysis system is compressed, so instead of appearing like this, they guys looks like this because of the compression from superior cord. That is known as drooping lily. So ectopic ureter will have an appearance drooping lily. Spider leg PCKD, cobra head, Ureterocele. Please remember this point is very important for your exams. See, same question again and again. Same the cobra head, another one cobra head image here. So it is a ectopic, it is a ureterocele. C. Cobra head or adder head appearance. Very good. This is an interesting image, not asked for your exam. This is a question showing you. You can see here the ureter looks like what? See the appearance. It looks like this shepherd crook. It looks like shepherd crook or fish hook sign. This is seen. They won't ask you, but I just wanted to complete the IVB appearance known as retrocaval ureter. So retrocaval ureter means the ureter goes behind the IVC and comes out. So that is known as retrocaval ureter. They will have this shepherd crook deformity. So this question already discussed in general. In horseshoe kidney, no need to do surgery. Horseshoe kidney does not need surgery. We have never done surgery for horseshoe kidney. Many people live with horseshoe kidney normally. Only one time we may need it to do operated, that is for abdominal aortic aneurysm. Otherwise, no need of surgery for horseshoe kidney. Putty kidney is a feature of tuberculosis. Tuberculosis, cement putty kidney means contracted calcified kidney. Okay, they will die. Both kidneys are putty, they will die. Patient sustains RTA, presents to emergency, where he is found to have a pelvic fracture. There is blood at tip of meatus. So it is again a classical finding of urethra injury. In an urethral injury, there will be blood flowing out through the urethral meatus. So blood at the urethral meatus causing urethral injury. In an urethral injury, there is a blood at the urethral meatus. What you should not do is Foley's catheter should not be put. What you should do? I should do a suprapubic catheter. Answer is SPC. What is the next immediate? Because there is a fullness of bladder. There is a fullness. We have to immediately put a suprapubic catheter, and then we will put a contrast and find out what is the problem, where is the injury later. Okay. So this is a classical question. You should not forget. Repeated question. So this is the image I told you, a picture showing you a calcified image in the bladder. What is this diagnosis? Calcification in the bladder. It is a bladder stone. So bladder stone. You are seeing a bladder stone here, which is seen on X-ray, plain X-ray. It is a plain X-ray. You are seeing a stone, bladder stone. Simple question. Virus causing arthritis. Mumps. These are all simple, straightforward urology questions. Mumps, arthritis can be seen in young age. 10 months boy presents with right testis in the inguinal region, left testis in the perineum. Same question repeated again. It is right side undescended, left side ectopic. Repeated. Last year, the same year, next question repeated. That is why I am telling you, please read the repeat question. Right? On the last day class, we got so many number of students. Today, the number of students are less because they are more stressed towards exam. In just 5 more days, you have an exam. But what I feel is, these are the questions you should go. Even if you are unable to attend the class, please share this PDF with your friends. Let them go through all these surgery questions. Just 180 to 200 questions. That's all. If you are thorough with these questions, all the 30 questions are going to be from this question bank only. 20 years old male presents with sudden onset of pain in the inguinoscrotal region following a sports activity. On examination, this is a catch point. Right testis is higher up position and tender on palpation. What is the diagnosis? So right testis is in higher up position, not in the normal position. So this is a higher up position, right testis. Left testis is a normal position. When will the testis go up? When there is a torsion. So answer is right side torsion testis. How to differentiate it from arthritis? I have to do a sign known as Prun sign. Prun sign will differentiate arthritis from torsion. In arthritis, if I lift the testis, pain decreases. In torsion, if I lift the testis, pain increases. Simple concept. That is known as Prun sign. If I lift the testis, pain increases means patient is having severe torsion. They will shout of pain. So torsion, pain increases. Arthritis, pain decreases. So young boy with a scrotal enlargement on investigation. You need, I should, to be frank, I also don't know this image. This is not my question. I am least bothered about the image, but I will answer this question from the clinical features. Scrotal enlargement, young fellow, young boy. Scrotal enlargement. LDH increased. HCG, AFP normal. There are only 2 types of tumors. One is seminomas and non-seminomas. You can see they have done an orchidectomy. That means I am sure it is a case of tumor. What tumor is it? Non-seminomatous tumors will have HCG increased, alpha fetoprotein will be increased. In seminomas, these are normal. That's all. Diagnosis over. In seminomas, they are normal. Non-seminomas, they are increased. In seminomas, what is increased? LDH is increased. That's all. Now you can come to the question. You will answer it. This is a simple flow chart. What tumor this boy would have had? Answer is seminoma. These are non-seminomas. Yolk sac, choriocarcinoma, teratoma are all also known as, they are known as non-seminomas. So non-seminomas will have increased alpha fetoprotein and increased HCG. Simple question, please don't forget. A newborn baby with an absent testis in the scrotum. Testis is found in the retroperitoneum above the deep ring. Which of the following may help in descent of the testis? So a newborn baby, the question actually missing here is, we want to know whether it is a term baby or a preterm baby. So might be the student recalled would have missed it. Term baby means, and preterm baby means I will wait and watch. Please remember, preterm baby means I will wait and watch. But if the baby is a term baby, I should go for a GnRH analogs can be given. GnRH analogs can be given, may help in descent. The answer is for a term baby is GnRH analogs, preterm baby is wait and watch. Simple question. So for an undescended testis, what age usually we operate? We operate at 6 months. Okay, when will you operate at undescended testis? If not coming down means I will do orchidopexy at 6 months. 65 years old male presents with painless hematuria. So painless hematuria is a feature of renal cell cancer. Simple question. If there is a painless hematuria, you should think of renal cell cancer. He has a palatable mass in the left flank. So they have classified very clearly kidney mass is there. On examination, RBC is present in the urine while WBC is absent in the urine. So this is to rule out pyelonephritis. In pyelonephritis, WBC will be present. So that is to rule out pyelonephritis, they have given RBC, WBC. WBC is absent, RBC is present. So most likely diagnosis is renal cell cancer. Simple. Okay, the question is having hematuria. There are two causes of hematuria in this choice. One, hematuria can be due to pyelonephritis or due to renal cell cancer. Only two things can cause hematuria in this choice. They themselves have ruled out it is not pyelonephritis because WBC is absent in the urine. See how brilliantly the question being set by the examiners. Though they look so simple, every word in the question is going to exclude one choice. So the moment you start preparing like exclusion of the choices, you will definitely crack this exam. A young male presented with a rupture of bulbar urethra. Where is the accumulation of urine seen? Simple question. So there is a urethra anatomy. It's an applied anatomy question again. This is prostatic urethra. This is bladder. This is membranous urethra. This is bulbar urethra. This is penile urethra. If bulbar urethra ruptures, usually it is seen in straddle injuries. I hope you know what is straddle injury. A fellow driving fast in a bicycle with a handlebar, the cycle chain goes and he falls on the handlebar with the groin. The bulb gets injured. The bulbar urethra gets injured. Walking into a manhole. So that guys will have a bulbar urethral injury. The urine will be seen subcutaneously in the chest. The urine will travel subcutaneously. When you put a needle, you can withdraw urine from these guys. In bulbar urethra, there is subcutaneous urine. In a membranous urethra, there is a perineum. Urine gets collected in the perineal urine. Please remember, membranous urethra, it is collected in the perineum, whereas in a bulbar urethra, it is collected in the subcutaneous regions. Okay. Mr. Gupta working in a dye industry presents with bladder cancer. What is the common type of cancer? This is a straightforward pathology question. Bladder cancer in a dye industry is usually a commonest cancer is transitional cell cancer. The bladder cancer commonly is transitional cell cancer. Is a common cancer of bladder. 5 years old girl. This question only I was telling you. Please listen to the question. 5 years old girl is having continuous dribbling of urine and also has normal micturition. Most likely causes. This question just now I explained. It is a case of ureteric opening distal to the external sphincter due to ectopic ureter. So the ectopic ureter is opening distal to the external urethral sphincter into the vestibule. That is why this girl is having paradoxical urinary incontinence. So this question again repeated. Mother while giving bath to a 7-day-old boy noticed in the scrotum of the baby is empty. You are the doctor. What treatment will you offer in this baby? This is a question which is actually probably the question was given a 7-month-old preterm baby. This question let us assume it's a preterm baby. We have to wait and watch. Preterm baby we wait and watch. Wait and watch is enough for this baby who is just 7 days old. Undescended testis is common in preterm baby. Undescended testis usually descends in 3 months of time. So we have to wait and watch until then. If testis is not descending, we will go for archaeopexy in 6 months to 1 year. And new concepts say GNRH analogs are tried to finding out whether there is secretion of testosterone, but not useful for these cases. And the recent books have mentioned testosterone GNRH analogs are not much useful for undescended testis from new concepts. So the latest concept is wait and watch for all guys. Up to 6 months we can wait, and 6 months we go for archaeopexy. This is the latest concept even for term or preterm babies. In that question there was no wait and watch. That is why we went for a GNRH analogs. Okay, but GNRH analogs are not much beneficial in latest studies. So what is the most common type of kidney stone? Simple question. So there are 4 questions from kidney stone. Most common is calcium oxalate stone. Most common in infection is triple phosphate stones, also known as struoid stones. Stone which is radiolucent stone is uric acid stone. Uric acid stone is radiolucent. Infection stone is triple phosphate. Most common is calcium oxalate. Calcium oxalate is of 2 types: calcium oxalate monohydrate, calcium oxalate dihydrate. Calcium oxalate monohydrate appear like this in urine examination. What is it? Examination of calcium oxalate monohydrate looks like dumbbell shaped crystals. Dumbbell shaped crystals are seen in calcium oxalate monohydrate. I think my laptop is going to have stuck up because 2 hours only the Surface Pro can withstand. That is why I am seeing the time. After some time now it will get hanged up like this. So let me fast finish the questions. So please don't forget, this is a uric acid stones, dumbbell in calcium oxalate monohydrate. In triple phosphate it will be looking like this, like a coffin lid. This is a coffin lid, like a coffin lid. Okay, coffin lid shaped crystals are seen in triple phosphate stones. So dumbbell shaped stones in calcium oxalate monohydrate. Triple phosphate will have a coffin lid crystal. So please don't forget these 2 important images. So coffin lid crystals are seen in triple phosphate. Whittaker test is a new question asked in FMGE December 2021, but it is a rare question. Nobody does this test. It is done for congenital this valve. There is a posterior urethral valve that will cause obstruction. This area will go for hydronephrosis. This area will be normal. So I have to measure the pressure in this place and in the bladder. So pressure in kidney and pressure in bladder will be measured. That is known as Whittaker test. Hydronephrosis to compare intrarenal and urinary bladder pressure. So this question is expected because it is asked in December 2021. So questions are going to end, only some 10 more questions. So just we will finish off fast. So yes, I can see there is a hanging because of the software. No, it will become so much hard, and the Surface Pro laptop will usually go for lag after a few hours. So Whittaker test is an expected question for pelviureteric obstruction. Okay, it is for pelviureteric obstruction. There is a obstruction at this place. We will measure the pressure here and the pressure here to differentiate the pressure. So the answer is hydronephrosis to compare intrarenal and bladder pressure. Whittaker test was done. Nobody is doing it now. It was done. So when I examine the scrotum, I am seeing 3 testicles. Interesting question, no? It is a direct line from Bayesian law. 3 testicle appearance is seen. This is normal testis. This is normal testis. This is a spermatocele. Spermatocele is 3 testicle appearance. 3 testicle appearance is seen in spermatocele. Spermatocele will have 3 testicle appearance. See, so many questions in urology. I need to take a separate urology class. That much number of questions in urology. An old age patient feeling heaviness in the left scrotum. He was suspecting cancer, came to ER. There was no pain or tenderness. Transillumination was negative. Most likely diagnosis in this patient would be. See, each line is excluding one problem. Let me tell one by one. There is no pain, which is ruled out. Epididymitis is ruled out. Simple. There is no pain. Epididymitis is ruled out. Ruled out. Testicular torsion is also ruled out. Testicular torsion also will have pain. Hydrocele will have transillumination. So that is also ruled out. So please, transillumination was negative. Hydrocele will have transillumination positive. So therefore, the final answer is varicocele. So I have to come to a diagnosis by ruling out the questions. By ruling out the questions, I have to come to a diagnosis here, that is varicocele testis. So let me complete fast because there will be so much of hanging after some time. So I will finish off as early as possible. 65 years old male presented with a mass in the left lumbar region which was palatable. He was having abdominal discomfort, and our investigation 7 into 5 into 3 centimeter renal cell cancer was noted. What will be the treatment? Simple question. They would have asked a single line. RCC, what is the treatment? Less than 7 centimeter, I will do nephrectomy. More than 7 centimeter, I will do radical nephrectomy. That's all. Simple question. So size less than 7 centimeter means I would have gone for partial. But this is more than 7 centimeter, I will go for a radical nephrectomy. So the answer is radical nephrectomy. So patient was operated for benign prostatic hyperplasia. On evaluation, incidentally, prostate was detected. Prostate cancer was detected. And on further workup, he was found to have metastasis. So prostate cancer with mets. What is the gold standard treatment? Prostate cancer is a hormone dependent cancer. So the treatment you should do immediately for a metastatic cancer is orchidectomy. But many old fellows, they will not be ready for orchidectomy. So therefore, we have to give some drugs which will stop the testosterone, that is goserelin. It is a drug which will stop the testosterone production. It is LHRH agonist. So the ideal treatment, if there is a choice known as orchidectomy, I would have gone for orchidectomy. But orchidectomy is not there, so I am going for a medical castration. That word we use for that is medical castration using LHRH agonist known as goserelin. Actually, it is a pharmacology question. Okay, goserelin. Young male presented with the enlargement of the scrotum along with the lump in the paraumbilical region and a swelling in the supraclavicular fossa. So this case is a case of tumor. Please remember, tumor. There is a tumor in the testis, paraiotic nodes, and there is left supraclavicular node. So it has spread. So it is a testicular tumor case. Testicular tumor is common in young males. The young male is having a tumor in the testis, paraiotic node involvement, left supraclavicular node involvement. So it is a metastasis from all these areas. So paraiotic, left supraclavicular, it is testicular tumor. So these are December 2, 2021 questions. So you can highly expect the questions. Please remember, identify the following investigation and diagnosis. There are multiple cysts in an MRI. So this is an MRI. MRI shows multiple small cysts in the kidney. So that is therefore MRI of polycystic kidney disease. Simple question. MRI of polycystic kidney disease. 62-year-old female has kidney stone and treated with PCNL. After 2 days, she again comes to OPD with a chills and fever. What is the complication? So after PCNL, patients may develop bacterial sepsis, nothing else. She was having a bacterial urosepsis. Answer 31, it is A, urosepsis. Okay, urosepsis. Young male was found to have a testicular swelling after evaluation. High inguinal orchidectomy was done. What is the probable diagnosis? It is seminoma testis. So please remember, you can see in urology, they are more concerned with the seminoma testis. They are more concerned with the seminoma testis and concerned with the PCNL and concerned more with the case of varicocele torsion architis. You should be thorough with all these topics. Okay, these topics are very important for your exams. I think we have come to the last 10 questions or 15 questions. Let me move it fast before the net gets disconnected. Which ulcer is likely to develop a long-standing venous ulcer? Which cancer is likely to develop a cancer in long-standing venous ulcer? Or which ulcer is seen in a long-standing venous ulcer? It is simple question. Marjolin's ulcer. It is a squamous cell cancer. Please don't forget, it is a squamous cell cancer from Burns scar or from venous ulcer. This is 100 times asked question. So after varicose vein stripping procedure, which nerve can be injured? Nowadays, nobody is doing varicose vein stripping. So you may not get this question, but answer is neuralgia. We can injure saphenous nerve or sural nerve. So medially saphenous nerve, lateral sural nerve can be injured when doing a varicose vein stripping. So this is the question some of you are asking me already. So which of the following is best for diagnosis of pheochromocytoma? So please remember, this is urinary. If I am going to urine, the urine product is 24 urinary VMA only. So this metanephrine is a blood value. So plasma metanephrine metanephrines are measured usually. So urinary VMA is the best for diagnosis of pheochromocytoma. So answer is A, 24 hours VMA for pheochromocytoma. Which organ has the highest chances of graft rejection? It is gut, GIT. GIT will commonly get rejected compared to the other organs. Rodent ulcer is a basal cell cancer. Simple question on basal cell cancer. So I am sure 100% they are going to ask you some baby image. Baby, newborn baby with some anomalies. So this 6 months baby was presenting with the following presentation. What is the management protocol? This is nothing but umbilical hernia. Umbilical hernia, Bailey says it is operated in 5 years. Surgery done after 5 years. So but the correct answer is indication of surgery if not resolved by 2 years. We can operate after 2 years. We can operate after 2 years to 5 years. So the exact answer, this type of questions varies with different books, but surgery is done as per Bailey and Love. It is 5 years. Sabiston, it is 2 years. So I will tell you, you will go with the Bailey because your FMG examiners will ask only question from 5 years from Bailey and Love. So go for 5 years. After 5 years, we can operate. By that time, many times the umbilical hernia will get closed. So this is Bailey and Love surgery after 5 years. But NEET SS aspirants, we used to tell it as 2 years from Sabiston. A patient with the varicose veins comes to hospital. Intern was on duty. Which test he shall perform to rule out DVT? So deep vein thrombosis test is Perthes test. Please remember, Perthes, modified Perthes, Homans, Moses, all these are done for DVT clinical examination test. Perthes test, modified Perthes test, Homan sign, Moses sign, all are done for varicose veins. Left kidney is transplanted. Where will you place the new kidney? For example, I am going to transplant kidney for one person. This is a kidney which I am receiving. Where will I place this kidney? I won't remove the old kidneys. It will be that way. I will place the kidney in the iliac fossa. Kidney is a heterotopic grafting. Means the organ will be kept in non-anatomical place. Heterotopic grafting will be kept in the iliac fossa. Okay. So this already repeat question. What is the diagnosis? It is a case of EDH. This is a biconvex image EDH. 2-month-old baby having watery discharge, fluid leaking from umbilicus. You should tell the answer. It is urine coming from the umbilicus. Is a persistence of failure of involution of allantoic duct. That's nothing but urachus. Persistence of urachus is known as allantoic duct. That will cause coming of urine through the umbilicus. 35-year-old recently divorced male is suffering from palpitation, headache, diaphoresis. He visited psychiatrist. What should be the next step? What do you think this case is? This case is a case of headache means hypertension, sweating, hypertension, psychiatric episodes. What should be the next step? Means you should rule out pheochromocytoma. Check for catecholamines. So there will be question on P. There will be pressure, palpitation, aspiration means sweating. This is pheochromocytoma. So pressure, palpitation, perspiration, everything is seen in pheochromocytoma. So we have to check for catecholamines to rule out pheochromocytoma. Patient presents with complaints of palpitations. On examination, heart rate is 110, respiratory rate, BP is very high. She tells you that her mother has recently expired due to renal cell cancer. What investigation will you do for a high BP case? So this is again a same question. So you have to do measurement of 24 hours fractionated metanephrine or urinary VMA. So please remember, metanephrine should be measured in the serum, or urinary VMA should be measured for a pheochromocytoma. All these are pheochromocytoma questions. So there will be a question on pheochromocytoma definitely for your exams. A young woman presents as shown below, which is triggered by cold temperatures or emotional stress. Episode usually affects her fingers and toes with numbness and pain. There is no underlying illness or comorbidity. Comment on this phenomenon. When she is exposed to some stress or cold, her finger color changes. First it becomes white color, then it becomes blue color, then it becomes crimson red. This is a phenomenon of primary Raynaud's phenomenon. Without any underlying illness is primary. Because of scleroderma or some other underlying illness is secondary. So please remember, secondary is due to some other pathology. A 2-year-old child with sudden onset of breathlessness, wheezing and decreased breath sounds in the right lung. Chest X-ray shows diffuse opacity in the right hemithorax. What is the probable diagnosis? 2-year-old child has swallowed a foreign body. That foreign body has entered through the bronchus, through the right bronchus. It has entered the right lobe. So where will be the foreign body going means it will go to the right lower lobe and it will cause occlusion of this lobe. That is the question. So it is a foreign body aspiration. So right side, foreign body aspiration. Identify the ulcer. Some of you are very much interested in telling the ulcer. No, this is the ulcer. On the medial malleolus if it is found. So medial malleolus it is found, it is known as venous ulcer. Okay, we are finishing the last two questions. Young male on exposure to cold developed color changes in the finger repeatedly and landed to your clinic with these findings. What is your diagnosis? So this is a case of finger gangrene. So it is case of Bilious disease. So fingers and digits getting gangrenous is due to Bilious disease. So much of I think so much of buffering. Sorry, the last few questions. A newborn is found to have herniation of bowel and liver through the umbilicus, which is covered by a membrane. So this is covered by a membrane is known as omphalocele. Not having a covering membrane is gastroschisis. So no membrane is gastroschisis. When there is a membrane present, it is omphalocele. Please don't forget this point. So baby was born with a scaphoid abdomen, breathlessness, X-ray chest. So this is again a repeat question. They will ask you abdominal wall defects and they will ask you the baby with a bowel inside the chest. The baby is having a bowel inside the chest. This is nothing but congenital diaphragmatic hernia. So patient receives a renal transplant from his identical twin. This graft is known as allograft. It is known as allograft. So this is a basal cell cancer in the face. Basal cell cancer in the face. Old man with a metastasis in the bone and vertebra. What is the most likely diagnosis? It is prostatic cancer. Sorry, because of the net problem, I am just completing and giving you the PDFs. So patient underwent surgery which was immobilized for prolonged periods. He was found to have Homan sign positive. What is your diagnosis? It is DVT. I told you Homan sign positive is DVT. A old lady known case of atrial fibrillation developed sudden arterial occlusive disease. Which of the following is having poorer prognosis? That is paralysis. If the patient with the DVT is a case of DVT, when a case of she is a case of arterial embolus. If a embolus case developing paralysis, it is embolus. So please follow my Telegram channel on T-Borme Surgery Sixer. Surgery Sixer is my Telegram group. In that Telegram group, I will be sharing this PDF. So